Yes, sir. शेड्यूल तेरे पास है ना? So
careful, sir, careful. चलो वेब शुरू कर देते हैं डॉक्टर मीरा ने
हाँ शेड्यूल नहीं है 8 minutes आप उसको 7 minutes कर लो yeah.
Good afternoon, everyone. May I take this opportunity to welcome you all to the 65th annual academic meeting of the Grand Indian Orthopaedic Association, the mini IOACON at Jaipur, this 5th of March 2021. And this prestige session, what we have combined and call it like a IOA, Indian Orthopaedic Association, and ASSI, Association of Spine Surgeons of India, combined symposium on spine. Next 3 hours, we are going to be dealing with the most common orthopedic problems in spine, and we are going to learn about the nuances not only of the problem but how to manage them well. And we have the eminent faculty from Indian Orthopaedic Association, we have eminent faculty from the Rajasthan Spine Society, and of course we have the eminent faculty from Association of Spine Surgeons of India. But before I really move on, may I call upon the past president of ASSI, Dr. Ram Chadda, to give a welcome address, and then may I have Dr. Amit Jain from the IOA team to also deliver few words of welcome to all the delegates. Dr. Ram Chadda, please.
Thank you very much, Vishal. On behalf of the president of the ASSI, Dr. Shankaracharya, who's on his way to join us, I stand here welcoming all of you for IOCON 2020 in IOCON 2021, which is that we are having a mini IOCON representing last year's IOCON, and we would have this IOCON this year in Mumbai. I welcome each one of you on behalf of the Association of Spine Surgeons of India, and we look forward to this code share session where the ASSI and the IOA faculty have come together, and we are going to be talking about common spinal issues which would be tackled on a day-to-day basis by most orthopedic surgeons. We would be having various symposia and sessions beginning with lumbar canal stenosis, which is the commonest, moving on to spinal tuberculosis as we move forward. So again, it's a matter of immense privilege and prestige for the ASSI to be associated with the IOA. And we look forward to such associations where we can together work towards spreading academics and knowledge, not only in India, but all over the world. As I understand, this session is being aired through OrthoTV to various parts all over the world. So thank you very much, IOA. Thank you, ASSI. And thank you, the organizers from Rajasthan, for having us here. Thank you so much, Vishal.
Thank you, Dr. Ram. Dr. R.C. Meena, the president 2020 of IOA, he's busy with some other session. On behalf of the organizing chairman, Dr. R.C. Meena, the president 2020 of IOA, may I call upon Dr. Amit Jain to deliver a few welcome address before we start and jump onto the academic program. Dr. Amit Jain.
Thank you all. On behalf of IOA, I welcome you all to this mini IOCON. A lot has been said by our esteemed faculty, and I'm sure this session will be a great one as usual. I invite the chairmen for the session, Dr. I.P. Agarwal, Dr. Girish Gupta, and Dr. Chirayu Pamicha to chair the session. We'll be dealing with various issues of spine surgeries today and tomorrow in this session. And without wasting any more time, I request our first speaker of the day, Dr. Tarun, to come on the dais and start the session. Tarun.
Thank you, Amit. So first session today is on the commonest problem of lumbar canal stenosis, and the person who's going to moderate this session on lumbar canal stenosis, the most commonest problem that we all deal with, is none other than Dr. Ram Chadda, who's going to be moderating this session. And we have eminent faculty with us, Dr. Amit Jhala from Ahmedabad, Dr. Mihir Bapat from Mumbai, we have Dr. Chirayu from Udaipur, Dr. Girish Gupta, who's the endoscopic surgeon in Jaipur, Dr. IP Agarwal, another spine surgeon from Rajasthan. We have Dr. Ranjit Unnikrishnan and Dr. Amit also here to join us for the discussions. And let's have the first case shooting from Tarun. Tarun, over to you.
Thank you. Thank you, everyone. Very good afternoon to everyone. It's pleasure to talk in such a great academic feast. I am going to talk about lumbar radiculopathy or claudication. Radiculopathy means pain radiates down to the leg. Commonly, the pain is sharp of nature, electric or burning in sensation. It is usually associated with some kind of paresthesia. The pain is of acute or subacute in nature, and it aggravates with walking, sitting, standing, all type of activities, which increases the epidural pressure. And it is relieved with lying down condition. Whereas claudication is moreover chronic condition, which is caused by the ischemia of nerve roots, and the pain is felt as cramping or heaviness or a dull aching type of pain. It increased with walking and relieved with sitting or bending forward. So how to approach a patient of lumbar radiculopathy? Detailed history and examination is must, and history starts with age, the occupation of patient, any history of trauma, jerk or weightlifting, the complete details about pain, the site, onset, character, radiation, relieving and aggravating factors. You have to talk about comparison between back pain and leg pain. Which pain is more? What is the walking distance of patient? Is there any associated paresthesia or numbness or any constitutional symptoms, weakness or upper limb symptoms? Any history relevant to diabetes, renal disorders, thyroid disorders, which can cause peripheral neuropathy? And be ensured to ask about some red flags like bowel bladder incontinence, any significant weakness in legs or saddle anesthesia. Examination of patient starts with gait. Then we have to examine complete motor and sensory system of the patient, the muscle tone and bulk, the deep tendon reflexes, superficial reflexes, and in some spatial tests like SLR, cross SLR, and the femoral stretch test. But don't forget to examine the peripheral pulses, hip examination, and SI joint, because these are the biggest masqueraders of lumbar radiculopathy. To diagnose further, we have to investigate. And the first line of investigation, when MRI is readily available, then definitely MRI. If MRI is not readily available, then we can use a simple radiograph as a screening tool. Contrast MRI is needed when you suspect infection, tumors, or any history of previous spine surgery. When you have the patient imaging and patient findings, then you have to relate the imaging with the finding. And when there is poor clinical radiological correlation, then you can opt for EMG NCV. Don't underestimate the radiographs, and especially the AP and the lateral dynamic radiographs, which can point out the instability in spine. Like in this case, mechanical low back pain with left lower limb radiculopathy, clear-cut L4-5 listhesis is there, but don't forget to see the parasagittal imaging and the extraforaminal area, which can elicit the exact cause here. And the MRI can show you different type of causes of lumbar radiculopathy and claudication shown in this picture, like herniation, the stenosis part, the synovial cyst, any METs or the epidural lipomatosis or any abscess or the listhesis. Then surgeon can opt for a conservative trial, which is effective in most of the cases. But if conservative trial is failed, then the treatment would be surgical, which can be decompression plus minus fusion in certain indications. let's see a case. A 45-year-old female presented with left more than right lower limb neurogenic claudication for more than 2 years. The walking distance was 100 to 200 meters. There was no neurological deficit, no UMNL sign present. Hip, SI joint, and peripheral pulses was normal. These were the images. What should the treatment plan? Anyone? Dr. Rakesh? What should be the treatment plan in this based on these images?
You can evaluate the images and you can see that these are just MRIs. There is no plain image. And you have to have a look at what is happening in the canal and also what is happening in the fascicle joints.
Canal stenosis and erosion in intradiscal space.
First, we do the blood investigation. CBC, ESR, CRP, and X-ray.
So the blood investigations were normal. The clear cut, the finding in the sagittal image is L45 listhesis, L34 listhesis. But when you look at the L45 facets, you can clearly see the facetal effusion in the axial images, and that's why evident in the dynamic X-rays. There was clear cut instability at L45 as well as L34. So we did both level instrumented fusion as well as decompression. So to conclude, radiculopathy is most commonly a result of nerve compression, which can be caused by a wide range of pathology. Be ensured to inquire about all the specific red flags, clinical features. Conservative trial is effective in most of the cases, but definitive long-term management depends on the underlying cause. Thank you.
I think that's a nice presentation, Tarun. I think let's move on to the next talk by Dr. Ranjit, that not all radicular symptoms are sciatic in nature. So it's a very important talk, as he mentioned the masqueraders. So let's listen to that.
A very good afternoon. Thank you, Dr. Vishal. Thank you, IOA, and thank you, SSI. So we heard Dr. Tarun mention about the classic presentations of lumbar canal stenosis. So if you look at this image, will you project my image? So if you look at these 4 situations, all presented with back and leg pain. Looks quite similar, the MRI picture, which we all are used to seeing it regularly in our practice. All the 4 had different diagnoses. So the so-called sciatica mimicus. So classically, as Dr. Tarun mentioned, what is the radiculopathy? The classical pain and back in the gluteal region radiating down the leg in a dermatomal distribution. Now, when we are residents, we are taught these standard A, B, C, D. This is the reason why you can have a compressive radiculopathy. Could be an accessory vessel or a muscle, could be bone, an osteophyte pressing on the root, could be cancer, any tumor pressing on the root, or could be disc, out of which the most common thing is the disc. Now, is it always true? Now, we all know that when we get this classical history, classical exam findings, and classical imaging findings like this, we are more or less sure that this is a diagnosis of compressive radiculopathy. Now, there are problems because many a time we see patients who got multiple opinions and we kind of trying to inherit a diagnosis. Whenever we have atypical features in the history, and when we have a timeline of symptoms which does not fit into the classical story, we should be beware. Now, this patient whom she was a 68-year-old lady, was seeing for many years together for back and leg pain, thigh pain. I told her whenever she's having significant symptoms, come back to me. She was extremely obese, 140 kilogram size. We'll think about surgery because she was not disabled then. She came back to me in 2019, told the doctor, I'm severely disabled right now, cannot get up and walk, etc. She's obese, so I was more or less sure that this is now significant stenosis. I thought we'll go with surgery. I repeated the image, showed significant stenosis. Now, on the day 1, when she came back for surgery, I did not re-examine her because I know she was quite well. I got the MRI done. I again saw it. Well, this is stenosis, significant symptoms. On the pre-op night, I again, as it's customary for me to almost go and anyway re-examine the neurology and the patient. And when I examined her, this was the reason for her new onset of worsening. So had I not examined her, I got this hip X-ray done after the examination, not prior to that. And my orthopedic colleague went ahead and did this, and she was absolutely fine. She never needed anything for the spine. So what did I learn? Do not assume the diagnosis even if you know the patient. Repeat detailed examine on every visit you have with the patient. Do not use a borrowed diagnosis. Repeat imaging always prior to surgery or any intervention. Now, this review, a single surgeon single surgeon series of 600 patients, where we reviewed all the atypical features, causes of radiculopathy. The most common was peripheral neuropathy, followed by peripheral vascular disorders, hip and femur pathology, exospinal tumor, infections, and endartered neuropathy. We all might have the same experience in different ratios. The most common cause of a failed thing was 17%. There was non-radiculopathy, non-discal cause of radiculopathy. Now, this interesting paper where this, I always feel that this is an associated feature with our lumbar radiculopathy, myofascial pain. Most of them have got these. If you really look at it, I looked at my data, nearly 56% of the patients have got myofascial pain along with your disc symptoms. The so-called piriformis syndrome, the lateral femoral cutaneous neuropathy, or the meralgia parasitica, or the cranial nerve neuropathy. I've never seen it, I read it, or I've missed it, or the common peroneal nerve radiculopathy causing the lateral foot and leg pain. Now, another female, 34-year-old female, was having backache and leg pain for a long time, came back with this inherited diagnosis of radiculopathy. This was an MRI. She was having severe left-sided back and leg pain. So with this MRI, she was advised surgery. It was not fitting in. When I saw the MRI, if you really zoom up and see the MRI, she was advised surgery for the right side because there was a facetal cyst. And if you see very clearly, you know that the present worsening of pain was this annular tear on the left side. She was advised endoscopic surgery for the right side for the facial cyst, which was incidental finding. Her real cause was this annular tear, which obviously got better without any surgery. So what did I learn from this? Review the history and especially the timeline. Sudden worsening, something is wrong. You have to think why it happened. Understand and respect the natural history. This patient got better naturally. We all know that they all get better. Review the MRI finding with the clinical context. Don't go by what the MRI report says. Another patient, 62 years old, had back and leg pain for years together, was walking. He told me whenever he remembers, he's been on pregabalin for years together. Came back with difficulty in walking, was swaying, buckling of knees, etc. This MRI was taken, was advised surgery for stenosis. When I saw the MRI, he was having thigh weakness. He was seeing buckling of knee. Did not go well. Detailed exam, got a whole span MRI done. He was having upper limb weakness. Upper limb weakness and not fitting into a radiculopathy symptom. So this was another MRI repeated, and he actually had LETM. I saw my neurologist here got a transverse myelitis, LETM, longitudinal type. And that was the reason for his surgery. His CSF was done. It was positive, was given steroids and immunotherapy, got better. No surgery. Another male, 39, classical symptom, back and leg pain, was having occasional urinary disturbance, was advised surgery without an MRI, and came back to us, no motor weakness. Took an MRI, you see the obvious reason. He had an intradial tumor. We went ahead, removed it, came out to be a schwannoma, total release of symptoms. Again, another patient, she was a diabetic elderly in her 80s, was diabetic for 25 years plus. She always had paralysis in her leg, difficulty in walking. So she was told that you got diabetic neuropathy, so you have to live with it, and that was for her. And she developed bladder bowel symptoms, again for months together. Again, it was a diabetic neuropathy. You to happen here. She came back to us. She had, when I examined her, I rarely do a PR. I found a patulous anus. Got a CT done, and you can see it very well. This was a tumor. She had a tumor which was eroding into the bone, and that was causing the symptoms. When dad got a biopsy done, it came out to be a schwannoma which had eroded into the bone. This was a diagnosis. So the learning points again in this case: beware of overlap symptoms. Might be an old patient or somebody else's old patient, have got symptoms for a long time. Sudden change of symptoms or not looking typical. Please ask for this question very carefully in this setting, especially in diabetics. A lot of patients diabetics. And you have to have a low threshold for repeat imaging. If the MRI was repeated or a CT was done, this would not have been missed up to this stage. Another female, 49, she had back and leg pain, more of leg pain. This MRI was done. She was said that you got a disc problem, you go and see a spine surgeon. So when we saw, this was a reason for an MRI, you could see a uterine tumor, which was it. So to conclude, there are different causes of
extraspinal cause of pain, we have to have seen in different proportions in our practice. So the take home is, when you have a classical symptom, think of ABCD, which is the most common cause of radiculopathy. Don't entertain a borrowed diagnosis. Try to consider IVDP as diagnosis of exclusion, even with obvious imaging. I look at it as a exclusive. I see for everything else, then come to the spine as the cause. Review the history, clinical exam, and imaging prior to treatment again. When in doubt, do not hasten a diagnosis and advise surgery. Primum non nocere. Thank you.
Thank you, Dr. Ranjit. Do you want to discuss, Vishal, or shall we go? Yeah. So, Ranjit, here we are. I mean, very well pointed out all the points which are related to our branches. But have you ever observed, like, for patients having some gynecological diseases, they have some other problems, and then they have similar symptoms?
So, I had got a presentation of something called catamelic sciatica. So that classically is a gynecological problem with this endometriosis. You get cyclical sciatica. So I saw one patient. That's when I reviewed that. Okay. Cyclical sciatica. This endometriosis. Elsewhere, there is a bleeding into the sciatic, in the plexus, which increases on a monthly basis. And two, see, for me, like I said, I look at disc radiculopathy as a diagnosis exclusion. I look at everything else and then come to discuss the cause, even though it's quite obvious. That way, I try and decrease my chances of missing extra spontaneous cause of radiculopathy.
Okay, thanks.
How do you differentiate peripheral neuropathy, diabetic peripheral neuropathy, from concomitant lumbar canal stenosis?
So whenever I get bilateral symptoms, more of sensory than motor, and patient is classically having pain even at rest, and things, long-standing diabetes, etc., then my first thing is it is peripheral neuropathy. The sad thing is that nearly 1/4 times they overlap. So when in doubt, always I send to my neurologist. They do all the nerve studies, and then they say this is neuropathy. And there are times when we have patients with significant stenosis who have got significant neuropathy, and you have to operate for their disability. So I tell them that you will never get better 100%. You will have significant amount of paresthesia post-op. Be prepared for it. Only if your leg pain is disabling you significantly, think about surgery, and don't ever expect your pain to get better totally. So I bail out myself very first, even before surgery. And if you look at them, these patients whom you really want them, they're very happy after surgery because their claudication goes away. Their paresthesias decrease, don't never go away.
And what is the value? What is the importance of preoperative evaluation of post-word urine volume? Post-word volume.
Sir, any patient who comes with urinary symptoms, I get a urology, the post-word urine volume measurement. And today, even all cauda equina, now evidence is coming up that all cauda equinas need not have, all bladder symptoms need not be cauda equina. So today, even all my cauda equinas, you get a UDS study done, because we have organized system. We get a UDS in around 2 hours time. So if not at night, I get a UDS done, and my incidence of operating for the so-called bladder has decreased after this has been done. There's evidence coming up from ISIC Delhi, where they have done this. So after I read the paper, I've started doing this. I try and always document it.
One last question. For patients who have feeble DPA, PTA, but palpable, do you always do color Doppler?
Always.
What is your threshold when you always do it even in normal patients?
0. I get it when I'm going to operate on the spine. I want to have as many less number of failbacks as possible. So I do anything possible, including if you want a CT angio before I operate on the patient. So I have a very low threshold. I document it, not that I treat it. I documented that this patient has DPPT feeble, is a smoker or a diabetic. So it's documented that this patient has got XYZ. I always get it done, because surgery is a
going to put him on. I don't know how many of you use traction, but I do use that in my practice. We tell them to use orthosis only for a short duration. Medications are standard. We use a combo of analgesics, opioids. So I'm just going to actually see what is the evidence of all this. I won't go. So these two guidelines, which did come up long back, it's almost now 7-8 years. And they are like a review of each and everything what we do, whether pharmacologically, whether we use traction or not, whether to give a epidural block, which type of epidural block. So I'm just going to go one by one on each technique, what this guideline talks about when we are conservatively managing lumbar PIVD. The grades of recommendation are standard in this particular guideline, that A is good evidence, B is fair evidence. Till B, you can be sure, or maybe you can use it. C is poor quality. That means they're not sure whether this modality should be recommended. And I is insufficient evidence. So let's come to the pharmacological part. All of us know about non-steroidal anti-inflammatory drugs, tramadol, opioids, muscle relaxants. There are n number of combinations available. We use them day in, day out. Maybe Dr. Jhala will have some combination to his patient, and maybe Dr. Meir will differ with that. And we use that sometimes without science. We use them as per our own experience or practice. Whether to give steroid, that is one thing which is debatable. Whether there is any recommendation for that. So there is insufficient evidence to use IV glucocorticoids. So you should not, or probably avoid using IV glucocorticoids as per the guideline. For the 5-HT receptor inhibitors, there are n number of them. Amitriptyline, we have pregab, gabapentin. The evidence is again insufficient. And what they have noticed in those studies, in most of these studies, is that the results of using gabapentin or 5-HT antagonist, is similar to diclofenac sodium in the study. That's why they say that you can use it, but don't use them together. Don't try to put your patients for a long-term basis on an analgesic as well as a 5-HT antagonist. Try and move them to a 5-HT antagonist, which is more safer than a diclofenac sodium for a long-term basis. Similarly, about gabapentin, what they observed in gabapentin is that 3 times a day, you can go up to 2400 milligram per day. I know it's just going to dose off your patient, but that's what the guideline says. And it significantly reduces radicular pain, improves function for an acute disc. It is never to be recommended to any patient to be used on a long-term basis. So that is what the guideline says about gabapentin. Anti-TNF antibodies have shown good results. A single IV dose of infliximab 5 milligram per kg as a standalone treatment is not at all, as well as lifestyle modification. Their opinion is that a structured exercise program for patients with mild to moderate symptoms do well. So yes, physical therapy is a good technique, but you have to use it in combination with all the other modalities. Spinal manipulation, I think there is a lot of debate about it. There are people who are not qualified to do those manipulations. There are people who are qualified to do that. What even I have observed in my practice, that for the acute disc patient, if there is a qualified spinal guy, they do pretty well with that. These patients who have low back pain, they have acute symptoms, they subside with spinal manipulation, but it has to be properly supervised. If you have a mild disc, yes, it can be, but not for the patients who have a very severe disc, then it should be avoided strictly, and it has to be supervised. Role of traction, I think there is a lot of debate that no traction, no traction. But practically, if you ask me, there are patients who come to us with traction modalities, and they have done extremely well in the acute phase of the treatment. Lumbar traction, up to approximately nearly around 35 to 50% of the body weight of the patient, as per these guidelines. I know some of them sound weird because we really actually talk about them, but that is what these guidelines talk about. And they say that, yes, it has shown results according to, on the basis of large number of studies compiled together. They have concluded that traction, combination of ultrasound and low power laser were effective in treatment of patients who had acute lumbar discs. There is very little evidence to show that bracing or acupuncture or even TENS, which is so commonly used for our patients, is useful in lumbar disc radiculopathy. I think lumbar bracing or orthosis can be used as a treatment for a short duration, but we have to be sure to tell the patient that they don't use those belts and braces for a very long time, as it may weaken their musculature. These are some of the modalities which we commonly use in our outpatient, we recommend to our patients. About epidural steroid, there is grade A recommendation. It's an excellent technique. It gives excellent pain relief in patients who have acute PIVD. Fluoroscopy guided is the gold standard. It improves the accuracy of the medication delivery. And this is the dose which they have recommended, which is 70 milligram triamcinolone plus. This is what they have mentioned about that. Is there any recommendation for how frequent you need to give? No, there is no evidence to show that you have to repeat it after 3 weeks or 4 weeks or 6 weeks. There's no evidence like that. And about the technique, whether it is interlaminar is better or transforaminal or caudal, I think now most of us have moved to the transforaminal fluoroscopy guided technique, and this is what is now the gold standard. But the difference is not there. There is no sufficient evidence to say that this is superior and this is inferior. So the take home message is that bed rest, I think till pain is severe, motivate early mobilization to the patient. Physical therapy alone will never work. It has to be combined in conjunct with other modalities. LS belt and orthosis only to relieve acute pain, but it has to be discouraged on chronic use. Traction can be used in acute phase to relieve pain. Spinal manipulation can be used, but it has to be supervised and it is to be totally avoided in severe cases. Analgesics, I know there is a large group of analgesics available, but try and motivate your patient to go off chronic use of painkillers. Similar is 5-HT antagonist and gabapentin. IV and oral steroid is to be avoided. And spinal injections, transforaminal spinal epidural is gold standard, and it's a very useful technique to manage acute lumbar disc disease. Thank you.
Thank you, doctor. What do you mean by qualified spine manipulators?
Sorry, qualified?
Spine manipulators.
No, I think there are physios. I understand this. I have given a review of NAS guidelines. There are, in that countries, there are chiropractors and good trained physios who use modified techniques to manipulate the spine. We don't have it here, so I will not comment on that. I'm just giving you the guidelines that this is what they've observed, that if there are qualified spine specialist physios, they can really give good relief to patients, but then it has to be a mild to a moderate case. You cannot use for the severe PIVDs.
Now there is a trend of giving distal blocks.
Offer?
Distal blocks for neuritis, radicular pain.
Distal block?
Have you heard?
Peripheral blocks.
Peripheral. Yes.
These are the basically
yes.
Gore's technique.
This is
I'm not aware of
sodium channel blocks.
Sodium channel.
Okay,
I have.
block. Okay, I think that is the pain.
No, it's not always Suraj block. For 5 it is this one sinus tarsi. For S1 is Suraj block, and in my practice really works.
Okay.
It looks funny. It looks weird. How it can work? It really works. I tell you. In acute.
Every funny thing, if it works, doesn't make it sense.
There is no.
Is it like an acupuncture?
I don't have science.
No. It's not like.
I don't have science for this, but it really works. Yes.
Okay.
Basically, no. I will comment over there. Basically, according to theory, that the chemical radicular adhesive is there, and the tumor necrosis factor alpha and all interleukins are coming from disc to peripheral nerves. And if you block the peripheral nerve with the sodium channel blockers, then definitely it will get relief. Yes. Dorsal root ganglion. Exactly.
Sometimes it works equally to epidural. What do I tell you? We can do it at OPD.
So when I read these guidelines, even I was a bit. It's almost a 50-page booklet to read. So there were things, but this is something which they reviewed. This has come after that guide. Okay.
So,
yeah, 2014. Yeah, it's in 2014.
sir, I have a question that up to how much time we can wait for the conservative management if patient doesn't has any neurological deficit or the neurological signs? But MRI shows that there is a mechanical compression over the nerve root or the thecal side.
Yeah, I think there is, at least they say that conservative treatment should last for not less than 6 weeks. That is mentioned in that. But I think it is all patient specific. How much your patient is ready for the next procedure, or how much or he wants to come out of that pain. But in my experience, some patients who have dragged on and not got operated, they did extremely well at the end of 3-4 months. And epidural injection is a very minimally invasive kind of procedure which takes care of their pain to a large extent. I'm not sure about that answer. This is totally patient specific. But before 6 weeks, no, unless you have those red flags of having neurodeficit, cauda equina, and all that, that is a different story. But for a patient who's got just back pain and leg pain, I think you can give them time. And time they will take only if they have less pain. And I think epidural injection is a very useful technique in that.
May I just make a comment here? Whenever we have patients who are elderly, who come to us with lumbar canal stenosis, it's very important if they are showing radiological evidence of significant stenosis and they are not yet mentally ready for surgery, to take them aside and counsel them for their sphincter abnormalities. Ladies do not share their sphincter abnormalities with anybody, the elderly ladies in our country. And even men are not aware of their true post-void residue, which is actually interpreted as a small trickling or like a prostate or such things. So please spend some time, because as very rightly mentioned by Chirayu, only those patients who are having this early cauda equina, which remains unnoticed, are the ones who will go from an reversible to an irreversible phase with time. Most other patients will go in that waxing waning phase where most of them will improve. But if you missed even one who had this hidden or latent bladder bowel issue, they go into an irreversible phase, and then your surgery, whatever you do, you end up with patients having indwelling catheters for a prolonged period of time and having huge amount of bladder bowel issues for a prolonged period of time. So it makes sense in counseling the elderly for their sphincter issues in detail, of course, combining it with a PVR or a post-void residue, opinion of a urologist, or even urodynamic studies, as mentioned by Ranjit.
I think urodynamic study has a catch, actually. Sometimes it's like nerve conduction. Yeah. it's a big catch.
No,
on the urodynamic.
it's very technician and electrophysiologist dependent.
Yes.
Yes, it is.
It is.
But then there are those certain borderline situations where it makes a lot of difference and it helps you
agree.
decide.
Totally
It
agree.
even helps an undecided patient decide, and it makes sense.
Thank you.
Thank you, Dr. Chirayu. Our next speaker is Dr. Mihir Bapat, and he will talk over the surgical management of canal stenosis.
It's great to be back in Jaipur, and I thank all my previous speakers because they have just allowed me to summarize my talk here. As we all know, like Ram said, it's a slow model. Lumbar canal stenosis is a slow model of nerve compression. All of us are getting older. All of us are getting stenotic. The canals are going to get narrower and narrower with time. So it's not that all of us are going to require a surgery. So when we look at a lumbar canal stenosis patients, it's actually a movie. It's not a frame in time. And that is why you need to take your decisions very, very carefully. The patients usually complain of more back pain, intermittent leg pain, progressive disabilities, periods of adjustments, modifications of lifestyles that go on for maybe years together. And slowly their activities start dipping. The walking starts coming below 20 minutes. That means that your outdoor activities are now significantly going to get hampered. These are the patients usually between 1 to 2 years period where they come to you for opinions. You give them a surgical opinion, they get scared. They carry on. The activities keep reducing and slowly the walking starts coming below 5 minutes. That means they are confined more or less to their houses. They can't really go out. They have to avoid going out for functions, avoid doing travel. These are the patients who really want surgery, and you should be bold enough to counsel surgery for these patients. Till this period of time, you have been counseling a conservative management. Slowly, these patients start going into subtle complications where they start developing signs of weakness. That means they have altered gait when they start walking. They have chappal slipping from their feet. They have cauda equina syndromes when they have walked. And these are patients whom you have to recognize by a very, very diligent counseling. So the patient groups, as we all know, first it starts with back pain, then it moves to claudications, then it moves to specific radiculopathies, and a very selective group of patients will present as complications which may or may not be very obvious. So these are the patients that you have to recognize. So there can be rapid deteriorations, as Ranjit pointed out. It can be true radicular, it can be false radicular. But if it is a true radicular deterioration, it is usually an acute disc in a canal stenosis, an instability crisis or a listhesis crisis. You may have an osteoporotic fracture, which complicates the situation, or you may have a tandem stenosis, which is developing on top of your lumbar canal stenosis. So when it comes to counseling, this is the same chart. As I told you, for many years, it's going to be warn the patient, counsel the patient, modify the patient, treat the patient, as Chira, you said, with multiple modalities: acupressure, acupuncture, massage, electric current, traction, magnetic belt, heat therapy, needle therapy, vibration therapy, KKT, QT, Chinese bed, Korean bed, Seragin, medicines, injection, belts. So these are going to be going on for these patients. And the claudications is what? The claudications, I have eaten kachoris and all the sweets. So only sweetness is flowing out. So claudications is what these patients are going to demand surgery for. And the time of surgery is more patient oriented, which is slightly modified by the surgeon for the patient. So this is how the claudication surgeries are going to be there. But when the patients become significantly disabled and is yet scared of surgery, you have to assert the surgery on these patients, because slowly they are going to move towards the complications. You can have patients presented with sores on the feet because of chronic radiculopathy. And that is why the timing of surgery is suitable for these group of patients between 6 months to 1 year. As the literature says, best results are within 6 months. But who advises surgery for 6 months claudications? The patient will say, sorry, I'm going to another doctor. So this is how the patients behave. Now, LCS is a chronic adaptation, activity modification, slow neural thinning, progressive muscle wasting, activity loss. The age keeps advancing. The patient keeps getting older. The comorbidities of the patients advance simultaneously along with the lumbar canal stenosis. And this cycle keeps rotating endlessly. Chronicity doesn't help. Chronicity requires a longer rehabilitation period post-surgery. The paresthesias don't improve, and it reduces patient satisfaction. So the role of the surgeon is to time the surgery. There are multiple variables: body weight, muscle strength, lack of exercise, OA knees, OA hips, movement disorders, Parkinson's, previous strokes, poor vision, poor auditory sense, vertigo, osteoporosis. So all these on one side, with the radiology staring at you, narrow canal, instability, tropism, all this on the other side, which is tempting you towards the surgery. So what is the aim of surgery? It is improvement of claudication only, improvement of acute back spasm that may be related to an event, improvement in disability. That is the primary aim of this surgery. And because of that, the patient can have improved medical comorbidities. That means if the patient starts walking, naturally his blood pressure, diabetes, thyroid, and all other issues are going to come under control. Now, this is a 45-year-old gentleman, 170 kilos, BMI through the roof, narrow canal, calcified discs, caudine syndrome. So this patient really needs to be counseled about surgery. You have to look at the facets. You have to look at the facet orientations. You have to look how the canal is getting compromised because of various facetal orientations. You have to look at edema, which is facet joint effusions, which was pointed out by the previous speaker, and take decisions depending upon the evidence of instability. This is not moving. Yeah. So there can be a lot of permutations and combinations. This is a block vertebra with an instability, with a facet trophism, with a facet joint effusion. So your surgical variables keep changing with each case. So if you have a lateral recess stenosis, now the concept is of targeted decompression. Laminectomies are not in vogue. It is more or more getting minimized to the target area. If you have a central canal stenosis, I'll conclude in a minute. I praised Jaipur, so I get that 30 seconds. So central canal stenosis, that is where if you have more than 2 levels, the decision is between laminectomy even now versus a targeted multi-level minimally invasive surgery with Jhala would do. I need to take that okay out. Okay. Okay. So fusion, if you have an instability, revision stenosis always, usually if it is a stable listhesis with a facet effusion with a facet cyst, elective if it is a large central disc extrusion, degenerative kyphoscoliosis which you want to correct, or if it is an osteoporotic fracture. So concluding with a few examples, a facet effusion with minimal sort of instability, try to fuse because there is evidence that this is likely to deteriorate. If you have an hypermobile single level segment, don't try to be minimal here. Go in for a fusion, which is going to offer this patient a more stable result than a minimally invasive decompression. So gray zones, this is my concluding side. Decompression is a time-bound procedure. No matter how egoistic we are, we cannot make this patient well for life. These patients are going to come back with a restenosis at 6 to 8 years. You need to reoperate on them. And that is why when you counsel these patients, you have to be very, very careful of how you say it, how you put it, because the disability for the patient is going to keep worsening, as well as the stenosis is again going to keep worsening. Thank you.
One quick question. Still asking. So last slide, let me catch you there. There are so many variables you mentioned, and I'm sure to the naked eyes, most of these variables will either get missed or overlooked. Plus, now with the minimal invasive world catching up more, the world is going towards non-fusion technology more and more. More and more surgeries are becoming non-fusion surgeries. Even when variables are there, even when there is a slight listhesis which is stable, even when facet tropism is there, even when facet cysts are there, we tend to not fuse them on one hand. On the other hand, we also know that restenosis, progressive degeneration, and reoperation rate at 8 years, 10 years is increasing. So with both these hand in hand, where is the right balance? Should we have a blanket treatment of fusing all the lumbar canal stenosis with these features of tropism, facet stenosis, or we should just have a decompression for all and wait for restenosis to happen? Where is the balance between the two?
Yeah, so I think Vishal, that's a very important question. Like the patient is getting older, the surgeon is also getting older and learning through his mistakes. So the answer to this is that the concepts of lumbar canal stenosis is primary decompression and recognizing early instabilities. So according to me, if you have an evidence of an instability, it is better to err on the side of fusion. If you are fairly convinced that it is a stable segment, now the world is moving towards a minimal surgery without disturbing too much of bone, too much of facets, decompress the neural elements and let that segment be, because we know that degeneration may catch up at the same level or even at the adjacent level.
May I invite Dr. Jhala? So now let's jump into the operating room. And sir is going to talk about...
Thank you, IOACON and ASSI. So after all the things have been done, the patients have agreed for surgery. My task becomes very, very easy, just to operate. So because it's a combined program between IOACON and ASSI, mainly I'm going to talk on, not on minimally invasive, but on an open, regular decompressions. Yeah, I know that. Right. So we all know that in decompression, there is a stenosis because of the disc from the front and the facet joints from the side and the ligamentum flavum, which compresses from the back. It may come as a single level or it may come as a multi-level. And that's the main problem of lumbar canal stenosis. Everyone feels that it's an easy surgery and it's a bread and butter for even the spine surgeons as on today. And it's all easy to do it. But if the main purpose of lumbar canal stenosis, we all know, is enlarge the spinal canal, which is either central or lateral. That's the primary purpose of the surgery. You decompress the cauda equina and the nerve roots. And after all the things which have been evaluated previously, you find out whether you require a stabilization of this patient or not. But stabilization will become a secondary. The patient has come for your decompression of the cauda equina, and you require a decompression, which is one of the primary thing for lumbar canal stenosis. So beware, you can get such a canal also, where it's a totally zero canal, and surgeons should be bold and covered both the things, I would say. And this is what I have been taught by one of my senior professors, that surgeons should be bold and covered, because you have to always prevent dural injuries, and you have to prevent the root injuries in these tight adhesions in stenosis, where ligamentum flavum can be adhered to the dura. There can be other epidural ligaments which can, when you just pull it off, the dural tear can occur, and you have to do an adequate decompression even if you get a dural tear. So your primary purpose has to be solved. So that's what we need to do. Whether to fuse or not to fuse, we will consider it later. But the best surgical results will come if you have a clinical and radiological correlation, as was talked before, and a good surgical technique. Even if you have chosen the patient right, if you have not applied the technique properly, the results are not going to, you are not going to get the results. So what are the surgical prerequisites? You have to understand the pathoanatomy. Where is the compression? You should have a comfortable theater setup. You should have a proper instrumentation. You should have a good Carrison punches. You should have appropriate disc forceps. Everything should be proper. And you should have a good dissecting techniques. If you have all these things, you can have a good execution of the surgical technique. This is one thing for the juniors, if they want to start this decompression. This is very, very important figure. This is a coronal section. Actually, you are going to do and see these things. And you should know what are the different regions of the spine, because that you need to decompress them. So this is a central canal. This is a lateral canal. And the nerve root is going to be in the lateral canal just besides the pedicle. And that's a subarticular area that needs to be decompressed very well. And that's the foramen. The root goes out of the foramen. You have to decompress right up to the foramen. So these are the areas that you have to look in axial cuts also. And that's the foraminal stenosis. So what is the classic compression? The classic compression is at single level. And that is because of the ligamentum flavum. And the flavectomy is the main treatment for this. And you remove the ligamentum flavum and you enlarge the canal. Traditionally, you can do by laminectomy. You just go from the center. You widen the canal by removing the ligament, and the canal widens. That's the surgery of decompression. And this is what you will get it. But now we want to preserve the posterior elements, because there is a post-operative instability which can develop in these patients. So there are surgeries which preserve the posterior elements. And this can be done either by bilateral fenestration. You preserve the midline. You go on the sides, on both the sides, and decompress on both the sides, and you enlarge the canal. So that's the second type of surgery that can be done for decompression. And the third type is really minimally invasive, that is in vogue as on today, wherein you just go from one side, put in your tube there, and then decompress both the sides, both the central canal and lateral canal on both the sides, only by going from one side. And that is known as over-the-top technique. And this is what you will be able to do, and you achieve the same result as in the open surgery. So now what I'm going to show is a video of a standard surgical steps for LCS, not of the minimally invasive, considering the audience that I'm catering to. The surgery is position, exposure. Sorry. I would do a laminectomy and bony work first, preserve the ligamentum flavum, till the end, and then do the central and lateral canal decompression, final check of all the nerve roots, and then hemostasis. So during each step, never be in a hurry. 3 most important things to keep in mind is patience, patience, and patience while doing this surgery. And speed in surgery should be an achievement, but not the aim. So never try to achieve that by doing faster. That's a small video. I'll just move it faster. So usually I infiltrate and the open, I do a subperiosteal dissection rather than using much of a cautery. This is an old video, but still, I usually do a subperiosteal dissection and less of a cautery dissection to preserve the tissues. So once that exposure is done, this is what, this is the head end, that is the foot end, this is the pars. You always preserve the facet joint, that's the facet joint capsule, that is the transverse process. So you should have an adequate exposure of all these things. Then start doing a laminectomy. While doing the laminectomy and removing the lamina, you must preserve the ligaments below and the ligaments above, wherever you want to. Supposing this is a fixation done there, I would like to preserve the ligament here so that there is no adjacent segment disease which develops. So once that is done, you do the whole bony work first. So that's the ligament at L4-5. We all know that the ligament is attached up to the middle of the upper lamina. So you remove the bone or till the upper lamina. Before removing the bone, you detach the ligament. So once you detach the ligament from the lamina and make a space, you'll be able to insert the kerrison very nicely there. And once the kerrison can go, you do the same thing at the upper level. And now you can see that 2 ligaments are very, very nicely seen. I have not touched and entered the spinal canal there. The most important part comes here, to extend it or to remove the ligament from below. And that's where usually the dural tear occurs. So before that, I would dissect that level and free the and put a patty there. This is a very important step. So once you've protected it, now the things become very easy of doing just a phlebectomy because everything is in front of you. Just enter, just remove the ligament from the center. You separate it on both the sides. You hold one of the ligament. Usually there are adhesions, so you dissect these adhesions before removing. And then I don't like to remove, but I like to remove the whole ligament as one piece. This is on one side. The same thing you can do on the other side. And once the ligaments are removed, you can very well see here that automatically the roots are decompressed because you have already done your bony work. So that's the root there. But what you need to do is to decompress at that level. But at the upper level, this is where the pedicle is. So this is where is the subarticular area, and the nerve root actually goes from and goes through the pedicle and comes out. This is the pars, comes out from here. Decompress that subarticular area. Never go directly perpendicular. You have to go at an angle to that so that don't damage the facet joints. You cannot remove more than 50% of the facet joints. Of course, this is a fusion case, but then you can see very well the root which is decompressed there also. So same thing you can see on the other sides. So that's the lower root, and that's the proper root. So you have decompressed all the 4 roots, and then you do the closure. So that's how the standard laminectomy I would do. And we all know that the best surgical results depends on the indications of a right patient, radiological correlation. You understand the pathoanatomy, where is exactly the compression, and do decompression accordingly, and you properly execute the surgical technique. Thank you very much.
I think that was an excellent video because everyone needs to know laminectomy before they go for those tubes. Yeah.
I got other minimally invasive, but I thought that this is the best thing for the audience.
Okay, perfect, sir. Are there any questions for Dr. Jala?
One step which is the most important step for successful surgery. What is that one step that you emphasize, whether it is patient positioning or level marking or bony laminectomy or lateral recess decompression is more important? What is that one step before you plan the surgery that runs the maximum in your mind?
It is always the root decompression that's very, very important. Sometimes you just do the central canal and you come out. You just do the central canal and come out. But it's very, very important to decompress the roots, because unless you decompress the root, the patient can have the decompression from the subarticular levels and the foramen. So I always see that if you want to decompress, you decompress from the subarticular level to the foraminal level. And that's very, very important for me.
And I think position is also important, because the
All
patient,
the steps are very important, but this is only one thing that is very important.
and the patient position is also important. We should decompress in extension. We should keep the spine in extension while decompressing, in my view. Yes.
Definitely. So I always, if you see the position, I just skip that, but it's always on the bolster. I never do on the Wilson's frame. I'll always do all my surgeries on the bolster, which are actually not vertical also. They are transverse. So you will get the best extension.
Sir, if there is only the foraminal stenosis due to the impingement of the superior articular process due to the collapsing of disc space, so how do you reach, and the spine is stable already, so how do you reach up to the foramen?
So there are 2 ways to do it. Either you do conventionally. If you want to do it conventionally, then you have to remove the facet joints, what you are talking about. But now if you want to do it, then I will do it by outside the foramen and do the foraminectomy from the outside the canal by the tube. I would do with the tube. That's also possible.
So you always fix that? No, there is no need. Okay.
No need to fix it if it's only single level.
Thank you, sir.
May I invite Dr. Ram? I think so. He's going to first talk about fusion in LCS, and then, of course, to continue with the panel discussion.
Good evening, everybody. At the outset, may I welcome President IOA 2020, Dr. R.C. Meena, organizing chairman of this conference. Welcome, sir. Thank you very much for gracing this combined IOA ASSI session. May I request you to please say a few words. Dr. Meena, please.
To be frank, if you ask truly from me, I do not have any word to express thanks and gratitude to the ASSI, who has given a so wonderful academic feast and academic knowledge to the common orthopedic surgeons of IOA members. And it was really unimaginary. कहिएगा कि मैंने कभी सोचा नहीं था कि इतना successful ये जाएगा. If you see, the AGM of IOA held 2 days earlier, 2-3 days earlier, hardly out of 13,000, 190 persons joined that AGM. We were expecting that it has to be joined at least by more than 1,000 or more than 500 persons. And your conference, your session of ASSI with IOA, IOCON 2020 was attended near about 13,000. That was unimaginable. And that has proved that the today's orthopedic surgeon and today's delegates and doctors do not believe in false concept of the association, who is who and what is who leader is doing. They only believe in the academics. They only believe in the specialty and expertise. That's why your collaboration with this IOCON has been a wonderful, achievement for this conference. Thank you very much. Keep it up and continue it for the future generation point of view. Thank you, sir. Thank you, Ram. So nice of you.
Thank you so much, Dr. Meena. It's indeed a pleasure to be here in Jaipur and be a part of the hospitality extended by the entire Jaipur team headed by Dr. R.C. Meena. May we have continuation of our academics. When do we really need to do fusion in lumbar canal stenosis? Let's understand some very basic concepts. Most lumbar canal stenosis in the elderly would be what we would call simple lumbar canal stenosis. Now, what is simple? If there is something simple, there has to be something complex. Simple is everything but for the following three. What are the following three? A lumbar canal stenosis with a degenerative lumbar scoliosis more than 20 degrees of Cobb. Are you understanding? Lumbar canal stenosis more than 20 degrees of Cobb can be looked at as a complex lumbar canal stenosis. Next, lumbar canal stenosis with an unstable degenerative listhesis. That means you have stenosis, but the patient also has L3-4 or L4-5 mobile listhesis, which are adding not just to the claudication, but to the back pain and additional radicular symptoms. So these are the two structural ones. And the third component, which has now been added and which is becoming very important because people are living longer, stenosis tends to get operated more than once. So it is lumbar canal stenosis in an already operated patient being called failed back surgery syndrome. Now, I have a little bit of a reservation using this word failed back surgery syndrome because I stand as an unfortunate spine surgeon because I haven't heard of failed total knee replacement syndrome, failed total hip replacement syndrome, failed fracture surgery syndrome. For some reason, all that failure has been labeled onto the spine surgeons, but we are very bold and we look at the light at the end of the tunnel and we believe that we can convert failures into success. So this is where we are. Can we, then predict when we should use implants and when we should not? Effectively, we have to understand one thing very clearly. If we can safely do a lumbar canal stenosis decompression without making the patient more unstable, which means we make the patient relieved of their claudication and leg symptoms, but do not create a potentially unstable spine, which may add to her or his significant back pain or early restenosis, we don't need to instrument. However, if any one of these decompressive procedures entails adding some iatrogenic instability, either by choice or by accident, we have to instrument. So please understand, LCS by itself does not necessarily need instrumentation. Please remember that. Even if you're doing an L3, L4, L5, S1 decompression, does not mean that I have to necessarily put implants. You can do a very good multi-level decompression without implants, provided you've stuck to this guideline that you're not enhancing, adding instability, or you're not missing out an instability in your diagnosis. If we were to add instrumented fusion, how do we do it? Most of the decompressions were from behind. So what we did initially was uninstrumented fusions. Years back, when people had L5 lysis with grade 1 listhesis and implants were not being used, people believed that you needed fusion. So people used to do a copious posterolateral or alar transverse fusion, keep the patients in bed for some time, give them a corset, and let them then walk with good bony fusion. However, when implants came in, they augmented to early mobilization and also enhanced not just the rate, but the quality of fusion over a period of time. Hence, uninstrumented fusion from behind was replaced by posterolateral instrumented fusion, like the one that was shown by Dr. Jhala in the operative case, where he decompressed, had put in 4 screws. He closed it, but I'm sure that he added a lot of bone graft between the transverse processes of L4 and L5 in that patient. So depending on where you access the patient from, either you can do a posterolateral fusion, or you can do an interbody fusion between the end plates of the vertebrae above and below, from a posterior biportal approach, not sacrificing too much beyond the medial edges of the facet, or go through one foramen and remove one complete facet from one side and do a transforaminal fusion. So these 3 come from behind. A lot of people started doing them from the front. Initially, we had a midline transperitoneal at L5S1 or an L45 retroperitoneal approach for an ALIF, anterior lumbar interbody fusion. Then we had people coming in from the oblique side as well as from the lateral side. So you got direct lateral as well as an oblique lateral fusion. So today you have options to fuse 360 degrees. As you can see there, there is an entity called T-lift. There is an entity called PLIF. There's an entity called X-lift or direct lateral D-lift. O-lift from the oblique side and an A-lift from the front, anterior. And the father of all these was pure posterolateral fusion within the intertransverse area. But before you do any fusion, you have to ask, why are you doing the fusion? Do you really need the fusion? This is the answer to why you need to do a fusion. You can stabilize unstable, painful motion segment. You can correct a deformity like listhesis that I spoke of, scoliosis that I spoke of, a post-operative flat back that I mentioned. And you can do both indirect and direct decompressions. What do I mean by indirect and direct? Direct is when you're going down straight and seeing those nerve roots. What is indirect? Besides seeing those nerve roots, when we jack up the disc height, we indirectly make those nerve roots more comfortable than they were with the superior articular process of one hitting the inferior articular process of the other vertebra. Let's begin with what I said, PLF, posterolateral fusion. You could do this uninstrumented or instrumented. Today, safety tells us to do it instrumented. We put graft in the posterolateral or the intertransverse space with or without instrumentation. This is called posterolateral fusion. Most important step in this is adequate exposure of the transverse processes, preparing that bed adequately. Please remember, the biggest non-forgiving mistake that you may do is leave that fusion to an assistant at the end of the surgery. Mind you, it is as important as placing that pedicular screw, if not more important. Spend enough time preparing that bed and then adorn the bride. Am I clear about what I'm saying? Preparation of that posterolateral bed is extremely important. This is what is done, where you decompress, put in those screws, and put a large amount of bone graft after having prepared that posterolateral bed completely. Yes, these fusions work if you've done a good job on day 1 during the operation. It works well in multi-segmental degenerative disorders or monosegmental low-grade listhesis without gross mobility on dynamic imaging. So this cannot actually correct something at the interbody level, but it can hold something well in situ, like a low-grade listhesis. It should be avoided, however, in grossly mobile instability or in very tall discs or in post-discectomy syndromes. When do we do a PLIF? Well, this is what we first used to do, because we used to put them biportal. We used to try and keep the facets intact. And we had not yet evolved to that phase which Jürgen Harms taught us later, that you could actually get half the sort of facet out from one side or the full facet out from one side and put in the graft from or the spacer from there. we used to retract the theca a little bit more than we do now with the T-lift. But if you used smaller cages, which were expandable, even at that time, which were available, 5mm tubes, this was also a brilliant operation. In fact, it was far more physiological than a T-lift. If you could put in a small 5mm tube, which could then expand to a 9.5 by 11 or 11.5 by 13 sized anterior interbody spacer. This is posterior lumbar interbody fusion. People like Clovard, Lin, and all of people use this initially in their initial studies. And this is what actually was the fusion factory which started in our country about 3 decades back. Still, we use a lot of this P-lifts when we do discitis surgery, where we go in, clean up that whole place. We may not be too ready to put in a spacer. So we pack in a good amount of graft with instrumentation. And a lot of them, once you've cleaned up that area and made that area healthy and given specific antibiotics, tend to fuse very, very well if you've done a good job from behind. It works also very, very well in high-grade spondylolisthesis, where you've actually corrected and that anterior foot plate or that area where you actually want to fuse is not too large. The amount of bone left of the L5, which is going to actually stand over the S1, is not too much. So it makes sense in having 2 supports on either side rather than a single support. So I tend to use it there also in the high grade. I also use it differentially with different height spacers in patients where I'm trying to correct a degen scoli, but from behind, not as good as these guys who are doing it from the front now. I also use it in times where I have to sort of get a more solid fusion, or if I have to sacrifice both the facets for some reason, which is something where not very common, but could be done at times. When do we do a T-lift? Well, this is the bread and butter as far as interbody fusion is concerned today. Graft is placed from one side. It could be titanium or polyethyl ether ketone. You have additional instrumentation. A lot of people talk of unilateral instrumentation. Please be wary of that. Go with both the sides L4 and both the sides L5 screws. Don't get carried away by putting only an implant from one side. I have the right to say it because I burnt my fingers doing it very often. Short-term results were great for the first 2 years. Later, I needed to revise many of them. So please don't get carried away by that bandwagon. Put 4 screws rather than just 2. In these patients, yes, you have to go and sacrifice a part of the superior articular and inferior articular facets because that is to enlarge that foramen. Do it as a part of the procedure. This is T-lift. What is done in this? Very, very clear. You put in a spacer from one side and you've put in your you've sacrificed the access from one side and you've actually decompressed, usually in unilateral symptoms where the other side, you can only do an indirect decompression or do a mini open and have a look at the other side. So this works well in most patients who come with unilateral symptoms. It's a gold standard. It's the best option in revision cases today, more from the perspective that you can actually go away and outside the primary decompressed area or from a fresh portal or sometimes even from the opposite side and put in the interbody spacer. So it works well. OLIF, something which is now becoming very, very popular, excellent, especially in degenerative scoliosis and in patients who need surgery, a revision surgery for an adjacent segment disease. Well, here you go in anterior or anterolateral to the psoas and put in your spacers from there. You need proper training. You need to have proper imaging, and you can ideally combine with intraoperative neuromonitoring because that is something which will be a part of your learning curve. What do you do in this? Well, initially they used to violate the psoas, but a lot of work is now happening where it is going anterior to the psoas, and hence the nerves can be more protected, and patients are getting lesser and lesser post-operative neurological superficial nerve root issues, which were there in the initial part of the surgery. It is an excellent surgery where you can do a stage 1 procedure from the front and you put multi-level anterior spacers, make the patient walk for a few days, and then go in later and do a percute posterior procedure. It's a really good procedure, but in those patients which in our country usually do not accept surgery, which is adult degenerative lumbar scoliosis. Again, remember in our country, there's a very high incidence of osteoporosis. Try and correct and get the bone stock good before attempting these surgeries. The long-term results may be guarded if you don't address the bone density issues in such patients. This is again a very, very beautiful procedure. It needs some training, But once you do it, it's a very good procedure because a lot of surgeries which you do from the front, you can really clean up those disc spaces and get a good bone-to-bone fusion. So it works beautifully well. Coming to the final stage, why do we do these surgeries? Well, you should have a purpose, which I spoke about, which is that it has to enhance fusion. What is the process? Well, you could choose anything from behind to the front, and the product. Don't get carried away by the product, but just look only at the purpose and the process. If you get carried away by products, you might attempt fusions like the one that I showed here. I have no idea what this fusion is. I have no idea who did it. And I have no idea how the patient is. I just know that the lady was in agony when the images were sent to me. And I really didn't know what to do, but to send her back to the index surgeon. So this is not a fusion operation. So be a little bit wary as far as jumping the bandwagon. And I say this because I always like to quote at the end of the slide that I've just shown something called as the Dunning-Kruger effect. The more you know, the less confident you're likely to be. Being experts know just how much they don't know. They tend to underestimate their ability, but it's easier to be overconfident when you have only a simple idea of how things are. Try not to make mistakes, the cautiousness of experts as a lack of understanding, nor to give much credence to lay people who appear confident but have only superficial knowledge. The whole problem, and now I'm quoting Bertrand Russell, the whole problem with the world is that fools and fanatics are so certain of themselves, yet wiser people are so full of doubts. Amit Jhala said that you have to be both confident and cautious. You have to be both willing to take the step, but be ready that you may have something which you have unexpected. Behind every successful person or a successful surgeon are a lot of unsuccessful results. Good results will come from experience. Experience will only and only come from bad results. Thank you very much for a patient hearing. Any questions on this? If not, we won't take much of cases. We can have a small summary statement at the end of it all, but I just want an open discussion.
Any questions on anything, any aspect of lumbar stenosis?
Sir, I have a question in fusion, not when we decompress or even if we decompress. One is posterolateral fusion when we do intertransverse fusion. But one thing is like in a trauma, when we can only decorticate the lamina and put bone graft there. So is that also giving good results or is it not to be tried?
Can you
Bone
repeat
graft,
the question?
bone graft on decorticated or prepared bed of over lamina.
On the lamina?
Yeah.
Now I'm going to say something which you can go back and check in literature. Pure posterior fusion over the lamina, okay, where lamina is intact, is superior to posterolateral intertransverse fusion.
Okay, sir.
Am I clear about what I'm saying?
Yes, sir.
Your pure posterior lamina to lamina fusion after having decorticated with an onlay graft will be superior because you got much more bony bed than those two flimsy intertransverse. We use the two flimsy intertransverse, unfortunately, because we've removed that entire lamina. So if the lamina is intact, please use it. Forget the intertransverse. It's a much better bed.
So one question to the all expert faculty and the panel. What is the role of postlateral fusion in today? Where do you do a postlateral fusion?
Anybody?
All the expert panel.
No, I would do that for a degenerative spine where I don't want to jack up the discs. I mean, it's a dry disc and it is a multi-level degenerative spine, which is, suppose it's a narrow canal and I've planned for fixation. Then I would do a posterolateral fusion rather than trying to distract all the disc spaces up and do this thing. Other than that, I think posterolateral fusion, we can add on if you are doing an interbody bone graft fusion. I am not putting a cage. If you're dealing with infection, you want to add on, then you can do it on the opposite side also as a fusion area. But otherwise, no. These are the two places where I would do a posterolateral.
I'm doing it if I have to fuse 3 levels or more, because interbody work in 3 levels and more becomes more challenging and cumbersome.
So that's a technical difficulty with the surgeon.
Yeah, 3 level or more interbody. I would do it.
Of course, if you go to the literature for degenerative listhesis, posterolateral fusion works, but I don't do it. I never do it posterolateral because I'm not that good a craftsman to get that fusion levels. Right. So current day, I use it only and only when, as somebody said, that I have to fuse 2 or 3 levels more, then I will just add a posterolateral fusion at the upper levels above the base, which is of a interbody. So that's where I would use. Yes.
No, I think all of us need to understand here is that posterolateral fusion still exists. All of us try to do a posterolateral fusion. Let me tell you, we have evolved. This question comes from our days where we believed on posterolateral fusions. Then we started doing PLIFs, and then we moved to TLIFs. Okay, so why has there been an evolution? Because we feel that the amount of stability that we can give with a 360-degree is more than the posterolateral fusion. So without doubt, in all cases, Amit Jhala would always try for a for an interbody fusion. But if the bone stock is good, if you really have good solid pedicle screws which are not going to move inside the bone, so you are clear that your osteoporosis is out. Your segment is relatively stiff, either a settled segment which you don't want to jack up, or there are very strong, rigid bridging osteophytes, or where there are fused facets. You may have a listhesis, people may still want to fuse, they have taken down bone in a narrow canal. So you still want to put in screws, but you don't want to do an interbody. You can still augment it with a posterolateral. So where you really do not want to work on your disc too much. But if you're going to work on your disc and you're going to anyway enter the disc, then you might as well put a cage. No, I'm talking about an unstable situation. So if you don't have an unstable situation, you get away with a posterolateral fusion.
So for me, I think posterolateral fusion is still one of the most dependable kind of fusions in my books, even today. So despite having done so many interbody fusions, 70-year-old lady with a stable kind of listhesis pre-operatively, where I'm not going to jack up the disc. Disc is already sleeping. I will not want to wake up and give a sleep medicine. So straightforward, a stable listhesis in an elderly gentleman, low back, sure shot posterolateral fusion. Yes. Yes, but so there is a stable listhesis. There is a stable listhesis with facet arthritis. I am probably destabilizing the facets, so I am adding only posterolateral because I know it is going to fuse. Yeah. Yes. Yes. Severe facet arthritis with a stable degenerative listhesis. Again, this is the cases which are auto-stabilizing and it only needs some support. You really don't want to jack up the whole hog and do this. Multi-level, like Amit just mentioned, again, takes a posterolateral fusion. High demand backs, collapsed disc spaces. Again, that is something that I would not want to jack up the disc space if I feel I have did a wide decompression of the exiting nerve roots. I think posterolateral really works wonders. High-grade spondylolisthesis, where it is not moving at all, and I know that it is like a grade 3, grade 4 with a collapsed disc space, and the patient has back pain, leg pain, both, and I did a wide decompression, and it is not moving, I would really depend upon a posterolateral fusion. It has worked wonders. There is enough literature to prove that, and I really would depend upon that to do a posterolateral fusion. If I am not reducing a high-grade listhesis, I would do a posterolateral fusion. Yeah, so these are the indications in my books. Yeah, both. What I'm saying is that these are the places where I do it. Interbody sure shot. Every patient, wherever there is even slightest of movement of disc pre-operatively, do interbody. Your posterolateral is going to fail. A tall disc, a young back, a demanding back, even a 70-year-old high grade, gentleman who's got a high demand back, I think I would surely do an interbody fusion in those patients. Single level fusions, mobile discs, tall discs, interbody fusion. And any patient where I'm attempting reduction, even in high grade listhesis, there are these lumbosacral kyphosis. So if I'm attempting reduction even of the kyphosis, I would do an interbody. I'll make it a point that I put in some case some graft inside to do interbody fusion there.
Just to not confuse the audience, you see, there are so many variables that you have talked about, which we don't have an objective criteria for. Right? So your criteria will be different, his criteria will be different. So what is the message that you want to give to the audience, whether it should be done or it should not be done?
Okay.
I think the message should be that if you are doing posterolateral fusion, then the technique is very important. I think that technique has to be really, really given time, and yeah, I mean, the
Exactly.
technique is very important.
So I think it's not an intertransverse fusion. It's not a casual procedure. It's a far more demanding procedure. It's a far more demanding procedure than an interbody fusion, because you are taking a chance with a narrow fusion bed. So it is not only the transverse process, it is the lateral side of your facets. You have to take down from tip of the transverse process to the tip of the transverse process. Your autologous bone graft is often minuscule to achieve an intertransverse fusion. You have to take down huge chunks of your iliac crest to really get a stable intertransverse fusion. So these were the disadvantages of intertransverse fusion, which slowly allowed the interbody to gain prominence.
Can I just make a small statement? And I'm trying to give words to the way I think, and which has also got inputs from all one of you, because each one of you has contributed. So I would do a posterolateral instrumented fusion in a potentially unstable spine. Hear every word I'm saying, where I don't think the patient merits an interbody fusion, or I technically cannot do an interbody fusion. Have you heard these two things? And just to generalize, in the first, where I don't think, where I'm looking at a settled down disc, elderly patient, and two, where I cannot, is where when I put in my screws, I can put cement augmented screws, but my interbody spacer will just sink in. So these are situations where I will be a big no-no to go interbody. Again, I will also not try to do an interbody fusion where I have not attempted or been able to move the interbody space. Again, can I make that very clear? So if I have not attempted to or been unable to, which means I'm fusing in C2. And just to make you think a little bit laterally, something which is to be a little bit different, just go back and think, which are the patients where I do just a laminectomy for a cervical myelopathy versus where I do a lateral mass? And just try to correlate that and bring it down, and you will get some sort of an answer. Where you are doing a lateral mass are the guys where you're doing posterolateral fusions here. And where you're doing just a laminectomy, you're doing uninstrumented work. Just give it a thought.
And also, when for audience, if you're planning for doing posterolateral fusion, prepare your bed first before putting the screws.
Yeah.
If you put the screws first, it's very difficult to prepare the bed. You don't get access.
Sir, I would just like to share on a lighter note. I had made a couple of such presentations in the state of Gujarat, and Amit Jala is there, where I spoke about preparing the bed and adorning the bride. And then unfortunately, I had a lot of issues. So I keep quiet and I don't say those words anymore. But yes, I agree. It is very important to prepare the bed. Thank you very much for a patient hearing.
Thank you, Dr. Ramchada. I think it was a wonderful session on lumbar canal stenosis, and it couldn't have been even more debatable or interesting than what it went in last 1.5 hours. Lumbar canal stenosis, I think it has been a mystery. It was a mystery, and it will, and it continues to remain a mystery, and forever it will be one. To summarize, I think lumbar canal stenosis is something that we all have to not only diagnose clinically, have to pay a lot more attention than what we usually do to find out if there is any hidden diagnosis behind, and clinical diagnosis is something that will always be very, very important. Patient selection is that one step that can either make your treatment successful or a super failure. And that is something that we all must pay attention to, right from spinal to the extraspinal causes of it. Conservative management has a definite role to play. And of course, surgical treatment, when it comes to hands, you have to be extremely patient, calm, and handy in principles of management. Not only decompression is a challenging job to do, however, the principles Dr. Amit Jala highlighted, you can surely achieve good results. At the same time, fusion sometimes is mandatory to be added, and there are lot many variables that need to be paid attention to when you're planning to do management of these lumbar canal stenosis patients. Thank you, everyone. Thank you, faculty, and thank you, the panelists around. May I now call upon our another set of panelists here. Our moderators for the session are Dr. Mihir Bapat and me, myself, who will be leading the show on the one and only session where we all are masters, where we all know everything about it. and yet we are the donkeys of spinal tuberculosis. May I welcome Dr. Mihir Bapat over with me. And the panelists for the session would be Dr. Ram Chadda, Dr. Girish Gupta, Dr. Ranjit Unnikrishnan, and may I also welcome in Dr. Amit Jain to join us for the session on spinal tuberculosis. Last year, yeah. So I thank again all the speakers of the previous session. We have Dr. Ram Chadda, Dr. Mihir Bapat, and Dr. Chirayu, and Dr. Ranjit Unnikrishnan join us. Dr. Girish to come up with the case presentation.
Good evening, everyone. And as Dr. Vishal described about the spinal tuberculosis, we think that all we know is about the spinal tuberculosis, and still is there need to hard work and need to do the finalize the all treatment modalities about the spinal tuberculosis. Is really there is need for to diagnose the spinal tuberculosis, that is there always need for biopsy, or is there always So I start with a case. 17-year-old girl had the severe backache. Patient had some mild grade of fever. Patient had loss of appetite, and patient was not able to move during sleep and even not able to move in the bed. So after the clinical presentation of patient, the first diagnosis in our mind generally comes with the spinal tuberculosis. So patient on examination, patient had tenderness, but patient had no neurological deficit. SLR couldn't elicited due to the pain. EHL and dorsiflexors of foot was 5/5, ankle jerk, knee jerk was normal, and there was severe paraspinal muscle spasm. So on lab investigations, there was ESR 90, CRP 35.62, and TLC was 5,000, near was 5,500. So would you anyone please, can you judge the diagnosis on that lab diagnosis on the lab investigations, on behalf of lab investigations and the clinical presentation and examination? Patient had severe low backache. There was no neurological deficit. 17-year-old girl, severe backache, mild grade fever, loss of appetite, night cries, not able to move in bed. So, so like Vishal, that first diagnosis in our mind is always like the spinal tuberculosis or the pot spine. And it was MRI. Sorry that I don't have the X-rays of that patient. And it was MRI. So still it is now TB? Spondylolisthesis. Okay. Yeah, definitely it is spondylodiscitis. And as like the radiologist always, it's called the pot spine. Most of radiologists of the any spine TB, any infective pathology in spine or the disc, they generally call the pot spine. So how will you deal with this patient on the MRI and the clinical presentation and lab investigations? How will you proceed? Biopsy. And how will you take the biopsy?
Because you have shown.
CT guided or transpedicular?
Okay.
Of course, there are various ways of doing it.
Though I am endoscopic spine surgeon, so I decided to the lavage as well as took the biopsy and the samples for the lab investigations. So I did the transforaminal endoscopic, and I do the discography to confirm the dye leak. Is it leaking or not? That my annular tear was there or not? So I confirmed that dye was not leaking posteriorly. So the annulus was completely intact posteriorly. So in this technique, we generally do with the local anesthesia. We do in the guide after the needling guide wire pass, then dilator and the cannula, and then finally the scope entered. So in this view, that the on second. In this slide, you can see that the water that is coming outside, that is not the complete transparent like that water looks. It is turbulent in nature, and so the pus is coming out with the lavage. So basically, I wanted to show the video of this patient of the how I did the gastric, how I did the lavage and took the biopsy, and how nicely I decompressed the thecal sac as well as the roots. And on same sitting, though patient was a severe patient had the severe backache, so I did the transfacetal fixation in local anesthesia. So in this left side, you can see that there is the cannula at in that intradiscal space, and while I was putting the transfacetal screw in the percutaneous manner. So I did the transfacetal fixation both sides, and it was the culture reports and the biopsy. There was no fungal infection. There was no tuberculosis. It was the pseudomonas infection. So young girl, 17-year-old girl, patient had the pseudomonal infection intradiscal. So I gave the empirical therapy, generally 3 weeks, IV antibiotics with the meropenem and ceftazidime, like the culture sensitivity reports, and then followed by the 3 weeks oral antibiotics, muscle relaxant, and LS belt support. So it was the post-op X-ray just after surgery and after the 30 months of follow-up. And these were the videos, but not playing here. Patient is comfortable right now, and patient is doing well. Thank you so much. So there are the questions that all spine infections are not tuberculosis, and if there is tuberculosis, how much time we should take the ATT, how should long the long or the short regime or the long regime we should give the ATT, or is there a need for any surgical intervention, or if there is need for surgical intervention, is there a need for short segment fixation or the long segment fixation? Should we do the fusion? So there are a lot of questions that are remaining and always controversial as well as debatable. Thank you so much.
Thank you very much, Girish. That was an excellent presentation. Any questions to this talk? Yes, please.
Especially when you do transforaminal infections, I just want to ask this question because patient was having severe pain. And whenever I do such a procedure, what do you mean by local anesthesia?
Sir,
because that's very, very important, because they are in such a severe pain sometimes that they cannot tolerate this procedure.
Exactly. Many times the patient can tolerate the pain with the local anesthesia. I use the lignocaine and the bupivacaine. And if patient is not tolerate, then I ask to my anesthesia to give the epidural analgesia.
In this case, the disc space is nearly gone. So if this patient would have come with a normal disc space, would you have done the same thing? Transfacetal screw?
Definitely, I do the transforaminal lavage first because it is easy
No, screw I'm asking.
Screw?
Yeah, transfacetal.
No, then I will not fuse the patient. I will not fuse the transfacetal fixation or any fusion.
Yeah. Thank you for an excellent presentation. This was really an eye-opener. It began in tuberculosis session by saying that all cases need not be tuberculosis and a biopsy is absolutely mandatory. So we call upon Ranjit now to tell us how to do a biopsy and what are the requirements of doing a biopsy. Thank you, sir.
Good evening once again. So with the slides, with the precedent of what Dr. Giri set up, anybody want to take a guess on the diagnosis on the case of the male 62 and the male 57? Any guesses? Has to be tuberculosis. So the one on the left, the male 62 is TB, right? And on the right side, male 57. This is osteoporotic, but you see a lot of soft tissue shadow. You saw a lot of soft tissue collection around the face, etc. It could be osteoporotic. Okay, and biopsy. Excellent. So this was reported as tuberculosis, came as myeloma, and the one on the right side was reported as myeloma, came as tuberculosis. So that's why we have to have a tissue diagnosis before we start. Nothing without a tissue diagnosis. So the question is: it mandatory? Yes. We saw the case which Dr. Girish demonstrated. Mistaken diagnosis, non-TB infection, resistant TB, other etiologies, to communicate scientifically, to have medico-legally save yourself that you are treating tuberculosis. So tips and tricks. Now, what are the deciding factors when you decide about the biopsy? Always consider the index pathology to be a tumor or infection, because you don't want to burn bridges. If it turns out to be a tumor, suppose a primary case, you want to do an unblock or something, you don't want to burn the bridges. So think it is like a tumor, follow all the principles. In the setting of a progressive deficit, there is no time to have tissue and all that, go it fast. So that's going to be a decompression in that setting. You have to review all the images, X-ray, CT, MRI, PET, before you decide the trajectory. You have to decide your trajectory, site of tissue based on your AP and lateral and axial imaging. You have to do this in your mind with experience or use a software or whatever. You have to plan your trajectory and look at what is available to you. Do you have a CT suite? Do you have a competent radiologist? That's very important. Not any radiologist. You have a competent radiologist. Do you have the lab facilities? Do you have molecular diagnostic facilities? Do you have OT and anesthetic facilities, which all of us have definitely? Can you transport the specimen safely, appropriately? So you don't want to have a dry tissue with the wrong transport. Now, when you plan the procedure, please emphasize to the patient that biopsy is not surgery. The moment you say biopsy, they get a surgery. So it should be very clear when we emphasize to them that tell them that there is a chance of negative biopsy and might need a repeat biopsy if warranted. You may or may not have further testing like PET CT, chest CT, etc. based on your biopsy outcome. You have to have appropriate imaging prior to biopsy. It's very, very important that many times this is where we have problems. Now the questions to you: do you do it open or CT guided? Do you do it under local anesthesia or general anesthesia? Do you do it in the theater or in your CT suite? Do you do it transpedicular versus paraspinal versus transforaminal versus transoral, as and when the site is? What test do you do and how do you transport? So we have heard this adage right from PG days: culture what you biopsy and biopsy what you culture. Quite obvious. So get all the battery of tests: gene expert, fungal cultures, TB cultures, and drug sensitivity for 10 drugs. The question arises: how do you do this? It's so expensive. Yes. So what our policy is that we take the tissue, bill them for 10 drug sensitivity. If that it is not TB, refund the money back. We have set up a system so that, because you cannot get a tissue again to do a drug culture. So it's billed and refunded if it is not TB. You have to get, when you suspect aerobic your needle might not, or your instrument might not reach transpedicularly. That is not a case for transpedicular access. Now, have this in mind. In those cases, you can go extrapedicular, trans-psoas, or based on the access what you have, but make sure you get the site correctly. If you go transpedicularly in a lower body lesion, you might not be able to angulate your instrument and reach there. You'll get a false biopsy. So those cases, go trans-psoas or as it is based on your facility and expertise. Now, this kind of lesion, a large lesion in the sacrum, you don't have to really open up. You know, you'll just take a nab and you'll get the tissue. So I try to always keep the patient prone and look at my image prone. That's where I'm going to go. So make a habit of seeing that. This kind of lesion, this is just a change of the edema in the bone. If I go paraspinal, I might not get anything. The better chance is to go transpedicular, especially in collapsed vertebra. If you're going to go inside, be sure that you are getting a good trajectory, or you have to open up the trajectory. I'll show how. Again, like these lesions, when you have the axial section is very, very important, the axial key. If you this image, you see that there is soft tissue component, there is bony component. You will have to angulate your needle or your instrument multiple times to get the adequate tissue. Another patient, look at this. You see the axial image. There is body involvement, but there is significant amount of soft tissue outside the pedicle. So this patient, I'm sure that my colleague, the interventionist, can get a tissue extrapedicularly. This is done on local anesthesia. I got a local anesthesia biopsy. It came up with tuberculosis, treated non-surgically. Another patient like this, where there's an epidural abscess in this situation. There is no point in wasting time trying to get tissue. Go ahead, decompress. Came out to be Klebsiella epidural abscess. So that's there again. This patient, another, looks like this. Complete collapsed vertebra, young male 47, middle-aged male 47. You can see here, there is enough tissue outside. Did extrapedicular access, extra costotrans approach, minimally got a tissue. Another lesion, the one which I showed earlier, this is a sacral lesion, came out to be a schwannoma with bony erosion. In this case, again, you don't want any transpedicular, extrapedicular access. You know, you will just put a nab, you get a tissue, but make sure you get the tissue. That's most important. Again, these patients, when I do intradiscal discitis, I don't fuse them transforaminally. I go transforaminally, get especially in these very obese patients, do a transforaminal debridement, get the tissue for culture. I don't fuse them. So in transpedicular access, what are the tips? It is a surgery. It is because it is transpedicular or it is percutaneous, need not be in an unsterile environment. It can be, it has to be or image or CM guided. So what I do typically is to use an awl to widen the pedicle, because you need multiple access, not just one bite. So I use an awl and make the pedicle bigger. And I have an awl which goes over a guide because I try and do it percutaneous also whenever possible. And don't use our routine pituitary punches to get into the pedicle. You will not reach there. You will not get enough space to angulate. And so don't use a disc forceps. What I use the endoscopy forceps, transpedicular, because it's a very slender one. It's 2 millimeter. It can go in the pedicle. We have typical pedicle 6 millimeter. You get enough space to angulate it. Always under image. I've plugged the iota once. So be very careful when you do it transpedicularly. Do it under image. Have the axial section in mind. And don't use these ones. They will not go to pedicle. You will get it in a pedicular lesion, but not into the body lesion where you really angulate well. And take multiple cores. So what are the final points? Review the appropriate imaging. Spend time. Good idea to take it on your software computer, plan left, right. Review the axial and sagittal plan very clearly. Plan your trajectory very well. Obtain adequate specimen and make sure it's on the right site. You have to transport them appropriately. If not, you might end up with a negative culture. In case of failure, consent them and be ready for a repeat procedure. Thank you. Any questions?
Great talk, Ranjit. Can we have a few questions? Ranjit, in your case, suppose you have a vertebra plana, not much of soft tissue, you have done a biopsy. The biopsy turns out to be negative. In your mind, you have a doubt whether this biopsy is correct or not. Would you repeat it again?
100% yes.
And the second time it comes negative, then what would you counsel this patient?
It depends what I'm operating the patient for. The patient has come with pain. I've done first a planar. Again, most of the planars, when you make a prone lateral, it might open up. open up, I'm more or less sure that I'll get some tissue. If I'm not getting it again, I might do a repeat. That time, not only percutaneous, I'll do a transpedicular open. And if they tell that I don't want to, because each time you get negative biopsy, you're going back by 7 to 10 days, because that's a time taken for the specimen to be processed and get the report. So in that second situation, I might go ahead and treat the pain in the same setting, probably stabilize that time, get more tissue.
So you have 2 negative biopsies now and an ESR of about 40. And you're not sure whether this is infection or not. Would you start empirical AKT or not?
Well, this in my situation is not uncommon. So what we do in this situation, we have got an infection board. We have an infection ID specialist, myself, physician, if it's a child pediatrician. We get them all. We discuss them, because off the hook, in my state, Kerala, where I come from, difficult people to deal with. The first case of medical legal suit was granted against an orthopedic surgeon for starting ATT for degenerative back pain on empirically and developed drug-induced hepatitis. The first case was granted. How did you start ATT without tissue diagnosis? This is way back in 1993. So extremely careful. I don't start anything empirically. I do start them, but with a board decision. So I split the risk. In those cases, well, why you said yes, I would get all this. I think it is like tuberculosis and start it off.
So suppose your board tells you don't start the ATT.
I don't start.
Then what would be your protocol of
I don't
management?
start, keep observing the patient, because disease tends to evolve. If it is tuberculosis, it is going to evolve. So I'll wait on it. Once the imaging becomes more clear, go ahead.
Perfect. So thank you, Ranjit, for this excellent overview on biopsy. That takes us to the next important talk by Vishal, the medical management of tuberculosis. Should we start empirical? Should we start primary? Should we start secondary? How much? How long?
So how many of us see patients of spinal tuberculosis one a week? Let me show of hand. Any hip, joint, knee, spine. How many of us deal and give medical management also by self? Like we manage and give AKT. I do most of the times. Okay, how many of us give it for 9 months? How many of us give it for 12 months? How many of us give it for 18 months? And how many of us use 4 drugs? How many of us use 5 drugs in first intensive phase? Okay, how many of us use injectables surely in intensive phase? Streptomycin. How many of us use ofloxacin in the intensive phase, or quinolones? Okay, the house is already divided, and that's what the beauty of spinal tuberculosis. And believe me, I'm sure everybody of here will vouch by your results that my way of managing spinal tuberculosis is really good, and all my patients are doing well. But that is not what we are here to talk about, that what is my way, his way, or their way. What we are going to talk about, what is the scientific way of medical management of tuberculosis. And let me, before at the onset, tell you that spinal tuberculosis is a medical disease, and 99% of all the spinal tuberculosis can be managed medically. And so if you pay attention to this talk, you'll be able to pay attention to the 99% of your patients, and the rest, Dr. Mihir and other guys who are going to speak about surgical management, will be only meant for 1%. After that, after this talk, you can actually sleep for 45 minutes. Because next session, again, I'm taking on osteoporosis again. So 99% of your talks pay 100% attention to this talk. And believe me, spinal tuberculosis is 100% a medical disease. And take my 100% guarantee that medical management of spinal tuberculosis never fails. Never means never fails. It's always the failure of the surgeon when they start treating it surgically. Why do I say so? That it's always better when it's treated medically, because non-surgical management or medical treatment of spinal tuberculosis can be guaranteed 100% if you follow rules. Don't mess with the rules and you will never miss to have a good result. What are the rules of it? Let's start one by one. Never miss by these rules of treating medical management in tuberculosis. And there are only 3 such rules. One has already said been the ground by both my previous speakers, that one, diagnosis shall be accurate and early. Appropriate AKT should be given. What is appropriate AKT? We are going to discuss in detail. And monitor healing absolutely stringently. Ensure compliance. Look for side effects and change the drugs as and when required as per scientific guidelines. So we are going to see them one by one. Please pay 100% attention to this so that 99% of your patients are better. Rule number 1. Tuberculosis is the biggest masquerader. Radiological also and clinical also. A TB can present with back pain, a TB can present asymptomatic, a TB can present with neurological deficit, and it is a radiological masquerader. A patient can have soft tissue abscess with spondylodiscitis, with destruction of bone, or it may just be a small bone marrow edema, or it can be multi-level, or it can be single vertebral body. So you cannot diagnose tuberculosis either clinically or radiologically, or even when both are put together. To diagnose tuberculosis, the only sure shot way is biopsy. Let me prove my point to this, that this lady, which is 69 female, like one of the previous cases shown here, with a DEXA of -3.9, and there is no neurodeficit, and there is a fracture there with a trivial fall there, and it was being treated like osteoporotic fracture, went on progressing, and came out to be TB. Why? What went wrong in this patient? We were always thinking that an elderly patient with osteoporotic DEXA scan like looking picture and a trivial fall would turn out to be osteoporotic fracture. But unless until you have an extremely high index of suspicion, you will never be able to diagnose 100% of your cases. And as I said, diagnose early, diagnose quickly, and that can only happen when you think Swadeshi, that every lesion in spine is tuberculosis unless proven otherwise. Even when clinical features are saying unless proven otherwise, it is tuberculosis. And vice versa is also true. What is vice versa? That every lesion in spine may not essentially be tuberculosis, like Ranjit pointed out. One such case example where a youngish male like Dr. Mihir, 46 male, back pain with fever, loss of appetite, having weight loss. He's been losing weight. Ranjit has been losing weight and he recently had fever also. But he never had TB. This gentleman also never had anything but a spinal lesion. They had night cries. And a typical triad of constitutional symptoms positive, clinical symptoms of back pain, and radiological spondylodiscitis, ESR positive. What comes to your mind? This is what we have been reading. Professor Tuli has been teaching us. There is a whole book on this. कि night cry होएगा, back pain होएगा, ESR बढ़ेगा, spine में discitis दिखेगा, तो TB होएगा, उसको TB का दवाई देने का. नहीं देने का. बिल्कुल नहीं देने का. It is not TB. This patient, despite having all the triads that we have been reading in our books, had not got TB despite medicines only worsened. Why? Because he had MDR TB. So despite having TB, he was not TB. He will never get better unless you have an extremely high index of suspicion. And this is purely because we over rely on MRI or we over rely on our clinical teachings. And the world is changing. Unless and until we change our thought process, we will always be having mistakes like these. And these are disastrous situations that can happen to our practice. For example, all these MRI pictures, they were based on our previous learnings, had constitutional symptoms and discitis, and were put on empirical AKT thinking that they are TB. None of them was tuberculosis. Isn't this a disaster? If that many patients come to your clinic every year and tell me कि डॉक्टर साहब आपने तो diagnosis ही गलत किया, treatment की तो बात ही छोड़ो. So all these mistakes can happen unless you have a high index of suspicion for TB. But at the same time, remember that MRI is only suggestive of tuberculosis. It is not diagnostic of tuberculosis. And unless you follow all the principles, what Dr. Ranjit mentioned and Girish highlighted, you will have disasters happening. And that's why diagnose early, quickly, and biopsy is the only way to diagnose tuberculosis. Always, for all spinal lesions, always do a biopsy. How to do biopsy? Ranjit will pass on his talk to you. Point number two. Point number two is even more important than point number one. After you have diagnosed TB, how do we treat it? Appropriate AKT. Remember, AKT is a chemotherapy. Here I would refer to what Professor Tuli has always been saying, that AKT is a chemotherapy. Do we ever give chemotherapy just like that? आओ ये 4 दवा ले लो, ये 5 दवा ले लो. My experience says 5 drugs work better. My experience says 9 months will work. My experience 18 months will work better. That's casual therapy. That's not empirical therapy. AKT has to be given in the manner it is supposed to be given. And how is it supposed to be given? Appropriate number of drugs, appropriate dosages, appropriate way to administer in optimal duration. And what is optimal duration? We'll talk about it. Appropriate drugs. Today it is proven you don't need an injectable if it is a sensitive tuberculosis. You just need 4 drugs. You don't need 5 drugs. And the regime that is recommended and is being followed today, Dr. Mihir and Ram, please agree with me if I'm wrong or not, but agree with me, right? So 3 months of HRZD, 3 months of HRZD and 6 months of HRE. This is the protocol today. Dr. Ram, you follow the same? Dr. Mihir? Chirai, any difference you follow? 3 months of HRZD and 6 months of HRE is the current protocol for primary tuberculosis, which is proven to be a sensitive tuberculosis. Dr. Amit, you follow the same pattern? Sometimes 12 months, yeah. So this is something that is there. And remember, if it is not responding even at 3 months, do not add one extra drug. By adding one extra drug, you are creating a MDR kind of situation. It's a failing regime. Second line is optimum dose. What is the optimum dose? It has to be weight adjusted. There are people who use these commercial preparations of Tetra Kit even in kids or even in adults. They would give 4 goli ek saath le lena, ya 2 goli subah lena, 2 goli sham ko lena. That is ridiculous. You are creating a disaster out of a simple tuberculosis, because AKT drugs, if they have to be given, they have to be weight adjusted. And a simple mnemonic, which I have learned in Bombay from my mentor sitting here across the table, is I ran straight to Panvel. IRSTP. I is for isoniazid, ran is rifampicin, 2. I ran straight, S is streptomycin, 2 is thiambutol, and Panvel is pyrazinamide. 5, 10, 15, 20, 25 milligram per kg body weight. Simple. Patient को वजन करने को बोलो and उसका उस हिसाब से वजन के हिसाब से drugs दे दो. Simple rule. And remember that within 6 weeks, this patient's weight will increase by 5 to 8 kgs. And so at every follow-up, at every 6 weeks, you have to measure the weight, and you may have to change the drugs. Otherwise, appropriate drugs on day 1 when patient had weight loss may become under dosages of the same patient in 6 weeks time. And this is something that we have to pay very much attention to. And remember, Arsenex or rifampicin and isoniazid have to give an empty stomach, even before any pantoprazole, even before antidiabetics, even before thyroid medication, because the moment you give them with these drugs, the absorption of these drugs go down, and appropriate doses of the drug may become under dosages. So all the patients should get an instruction, सुबह उठ के brush करने के बाद पहले गोली लेना, बाकी सब दुनिया का काम बाद में. And this is something that is extremely important. For example, in a patient who's taking metformin or Pandy, the absorption of Arsenex or rifampicin will go significantly down, reducing the actual most efficacious drug in patient's body. And this has to be paid very much attention to. Some very simple example, 38-year-old male, 100 kg body weight, obese, diabetic, and this is his prescription. Is this correct? He's on Tetra Kit, he's on Benadon, he's on Omaze, he's taking meals, post-meal drugs, he's taking Shelcal also, he's taking Farium also, Metformin also. So every single drug here, be it Metformin, Farium, Shelcal, Omaze, is a chelating agent. It will reduce the efficacy and bioavailability of these drugs, creating a disaster. And remember, by underdosing the drugs, we are creating a monster for this patient, and we are probably creating MDR, which will spread in no matter of time, which is a disaster to treat. And this is something that we all must remember. So just to run through the mnemonic that we just saw, and to rule out the message number 2, that AKT is a chemotherapy. Please do not take it lightly. And all these patients must be given weight adjusted, time bound treatment in proper dosages, and avoid drug interactions. It is your primary duty if you're treating this patient. Rule number 3, which is again another very important aspect, is ensure compliance. And ensuring compliance only means telling them about these subtle side effects. Because there are so many of our patients, probably in the villages and peripheral areas, who will, after taking first dose of Arsenex, will have red sweat, will have red urine, and they will stop their medication. कि साहब दवा लेते ही खून निकलने लगा, मेरे पसीने में से खून आने लगा, or they get these rashes and they'll stop the medicines and they will go to some other doctor, some Ayurvedic, some homeopathic, or someone else. So remember, you have to tell them that all these side effects are okay to happen. Don't stop your drug. The only situation when you stop your drug is when there is alarming side effects of vision loss, jaundice, or any of major problem that is mentioned in any of the drug listing there. So any of these side effects, you have to counsel them well that please don't stop with the upper. They are not alarming. If it happens, it is known to happen. So don't stop your medication. And in fact, I have heard from Dr. Rajashekharan that he tells his patients, दवा बंद किया तो ये टीबी दिमाग को चला जाएगा और परिवार में फैल जाएगा. So these patients, if they have side effect, even before they stop, they will eat the morning ka medication and come and tell कि साहब ये side effect हुआ था, which is such a nice thing to happen. You have to tell them, otherwise they'll stop it, and stopping it medication is only creating defaulters. You know, 2 दिन लिया, 2 दिन नहीं लिया, 2 दिन लिया, 2 दिन नहीं लिया. So that's not something. Please spare me. I mean, I'm not quoting Dr. Raja's words here. Raja sir is watching. They'll kill me there. Online, so we are being watched online as well. So what I'm trying to tell you is that
don't have to worry. Raja doesn't speak or understand Hindi, yeah. So don't worry.
So this is something what I'm trying to emphasize, that ensuring compliance is also our duty, and to ensure compliance, government is spending billions and billions of rupees by running a DOTS program. And we as the healthcare workers can also run a self-DOT program where we directly observe whether they are compliant to this treatment or not. And this is our duty. If we don't do it, tomorrow the same patient may turn into a disaster. How do we monitor healing? Now we have ensured compliance. How do we see this patient? 6 हफ्ते के बाद आया तो should he come and tell us कि सब ठीक है? No. The first thing that we should expect in 6 to 12 weeks time is general well-being. Doctor साहब दर्द वैसा ही है, but थोड़ा ठीक लग रहा है. थोड़ा वजन बढ़ गया है, थोड़ा बुखार कम हो गया, थोड़ी बुखार अच्छी हो गई, थोड़ा पेट का भूख अच्छा हो गया. If you hear these symptoms, you know your medicines are working. Don't rely on complete pain relief in 6 to 12 weeks, because if at the end of 6 to 12 weeks patient is saying कि थोड़ा दर्द बाकी है, it is okay. Be patient. It is going to take its own time for the bone to resolve. You being in hurry, adding a new drug is again creating a monster, because addition of new drug, कि अरे मेरा दवाई काम नहीं कर रहा है, and you do a new biopsy or you operate upon this, that's not a right thing to do. And monitoring is a three-dimensional thing. You got to clinically monitor them. You got to do a ESR, CRP, and CBC. You also got to check if there is any jaundice or uric acid that is rising up. And you also got to do X-ray to see if the osteopenia is getting better. So it has to be three-dimensional. And unless until worsening is seen on all these three parameters, there is no need to change any drug or any regime in all these patients. One such example, 55 female with all the sensitivity patterns detected in after a biopsy. At the start of AKT, that's the kind of MRI. And in 2 months, the patient is okay, but abscess बढ़ गया है. Dr. Amit, what would you do? 2 months MRI, patient is very sensitive, has done a 2-month MRI, and MRI reports shows that abscess has increased.
I'll see clinically what the patient is.
But Tarun, you won't add levofloxacin. It is available, Baba. Doctor, क्या कर रहा है? 4 drug में तो abscess बढ़ गया है. What will I do now? Doctor, what will you do? I don't want to get treated by this doctor. He's not paying time and attention to me. He's not adding new drug. Sir? Wait and watch. So not to add levofloxacin there, sir, not to add any drug. Unfortunately, this patient had 1 drug added there. And in another 3 months time, patient had some back pain, which was still persistent, got a new MRI done, and the abscess was further increasing, but there was nothing else happening. Now what to do? Tarun, अभी 3.5 महीना हो गया है, abscess बढ़ रहा है, डॉक्टर साहब. जाऊं दूसरे पेशेंट के डॉक्टर के पास? No. तो ऐड करें ड्रग एक और? No. Mir sir, what would you do? How do you expect resolution of abscess over a period of AKT?
Yeah, so I think the first 3 to 4 months, the abscess can increase in size because there's always a lag between the disease control and the inception of AKT.
Thank you so much, Dr. Mihir. I think this is one line that I wanted to hear and convey across, is that there is a significant lag in radiological improvement versus clinical improvement when a patient is on AKT, because MRIs will improve at a later date. In fact, in initial 2-3 months, expect that the abscess is going to increase, and addition of drugs like these, because they are at your disposal, is a creation of a disaster and monster in making. So before any other drug, you got to really think about this, because radiological worsening is defined not by increase in the abscess size, but only by increase in the lesions in bone. So if the new vertebral body lesion happens, or if a new bone gets infected, only then you need to think of it as a radiological worsening. Only when patient symptoms change the character, not the intensity, character. From clinical mechanical, it becomes neurological. That's when you think that something has to be changed. For all other patients, keep patient. It takes time for it to get better, and respect the lag that is in there. So just my last slide coming up. So frequent and very important monitoring of the patient of healing in a 3-dimensional manner. Do not add drugs to a failing regime, and call it a failing regime only when there is a change in character of symptoms, or radiologically you see new lesions appearing or new bone formation happening, or despite 3 months of your AKT, patient's symptoms continuously persist to progress and the patient's neurological symptoms start appearing. It's only then what you would want to do is to repeat a biopsy to see if a primarily sensitive AKT, sensitive TB has got converted into a MDR TB or something. And do not keep adding drugs. This is the time that you may want to diagnose rather than treat these patients. So just to summarize, AKT is a serious drug. It's a chemotherapy. It's not a empirical therapy. It is not a casual therapy to be given. It's something serious, and it has limited role today to play unless until you have done a biopsy. It has promising results to a tune of 99% of all the patients that, as I just mentioned, if you give it in the manner that we just discussed and monitor all these patients, ensure compliance, it's all our duty to prevent the emergence of MDR from here. Thank you so much. You're welcome to hear the rest 1% patients from the next speaker.
Thank you, Vishal. Does anyone have any questions for Vishal?
Yes, Girish. Next talk.
Sir, regarding the ATT, there were so much confusion. Then we should continue give the drugs continuously, means daily basis, or like the DOTS regime, like the 3 times in a week. So what would you suggest?
Off the camera. Look, let the camera be on. I mean, out of the records here, in our country now, tuberculosis is a notifiable disease. So being a notifiable disease means that we have to not only notify the disease to the authorities, but also notify the disease to the patient himself and tell him about his rights, that number one, you have this disease for which this kind of treatment is available with government authorities free of cost, and you are free to go and choose your treatment there. Now, as a surgeon or a medical physician, what we do is we either tend to refer it to our chest physicians, who are better off in treating these patients medically, because the side effects of these medicines can be immense, and for us to follow up is not so good, and not the best people to do that. However, when I'm talking on this podium where thousands of people across the country are going to be treating these patients self, if the patient goes to government OPD, I think there is a provision of daily drugs now in DOTS also. It is not an alternative regime, and that's what we prefer. In my practice, after having notified the disease to my officer, also to my patient, I give the patient the option that whether you want to get treated by me, because in my hands, in my books, this is what we have learned. This works really well in our hands, and I use a daily regime. I use, as I said, 4 drugs, 3 months in intensive phase, and 3 drugs, 6 months in continuation phase. So mine is daily 4 plus 3, 3 plus 6 months.
But regarding the intermittent therapy, there is a logic that the all anti-tubercular drugs has the lag effect. Means what the drugs you are giving, the isoniazid or the rifampicin, if you stop that for a day, they works for 2 days. They have the lag effect. So is it true, or that we should go?
Oh, that is too much of physiology. I'm a surgeon. I don't know about it.
Second question, that sir, we generally give the rifampicin is empty stomach.
Yes.
While
Always.
the isoniazid and the ethambutol and the pyrazimide.
Yes.
Generally, these drugs come either the 2 tablets form or the single tablet form.
Yes. Yes.
So either we should give the all 3 tablets on a single time, or we should keep some gap between the pyrazimide.
So the basic guideline is primarily for rifampicin. Rifampicin has to go early morning, before breakfast, before meals, and there has to be a gap of minimum 30 minutes after the drug before you take anything else by mouth. So the primary guidelines for rifampicin. Now, fortunately, I would not say unfortunately, fortunately, rifampicin is available in combination form with isoniazid. And for isoniazid, there is no such guideline that it should go empty stomach or after meals. So even if you take it early morning, before breakfast, empty stomach, you are doing no harm. However, rifampicin has surely got to go empty stomach. And this is what you have to emphasize to all your patients. And drug interactions are also more when rifampicin is taken with chelatic agents rather than with isoniazid.
Thank you, Vishal. There's going to be endless questions on AKT.
Yes,
I'm
sir.
sure.
Yeah.
So both of you can
We'll catch up
on
on
tea.
Thank you.
By the way, your primary diagnosis was wrong. I'm 48 years old. And I, in the morning, had lots of sweets. I have not lost weight. I don't have constitutional symptoms.
Oh, thank you. So you don't have tuberculosis
So
clinically.
now I rely 1% on RAM to tell me what surgeries are required for tuberculosis.
Thank you very much, Vishal, and thank you very much, Mihir. It's very, very interesting that I would now give a brief presentation on that 1% that Vishal alludes to would need surgery. I am going to speak in very short bullets, which will help us take decisions, and then Mihir is going to have an elaborate surgical presentation as well. As I've always said, surgery in active spinal tuberculosis is a team approach. We may be not qualified to write the medicines as well, but we are very much qualified to do that 1%, which is surgery. And we should not go wrong in either taking the decision or in executing the same. If we are to look at routine surgery in a complete large scenario of chemotherapy, the role of surgery is very, very limited, because this is a Cochrane collaboration, that it is a medical degree. Routine surgery cannot be recommended unless within the context of a large, well-conducted randomized controlled trial. Who all are party to the team that I work with when I treat a patient with spinal tuberculosis? I need a good radiologist, including an interventional radiologist. I need a pulmonologist, because I cannot answer most of the questions that Dr. Girish was asking. I need a microbiologist who's going to do justice to the biopsy that my interventional radiologist may be doing. And at the end of it, when I get all the information from these guys, I may operate on that one patient out of 100 who deserves surgical intervention. Yet, I do not, and I would like to say this with a lot of vehement stress, that I do not ever operate on a patient unless there is an impending neurology without a biopsy. Every patient who is subjected to surgery has to have a confirmatory biopsy if time allows the same. What do I mean by time? If he or she is not rapidly going down neurologically. Suspected tuberculous lesions are subjected to a biopsy if there's no clinical evidence of an extra-osseous disease and provided the lesion is in an accessible area. There are certain areas which are inaccessible or difficult. You have to look for other areas where you may find the same disease. If you have occipitocervical tuberculosis, difficult to biopsy, but you find a large lymph node, you can biopsy the lymph node. If you have a difficult lesion which you can't pick up, an MRI might show that there is also an iliac lesion or a sacroiliac lesion. You can biopsy that lesion. So keep that at the back of your mind. This is what my standard CT biopsy prescription states, and you're most welcome to take down these points. It includes a histopathological examination, a gram staining and anaerobic or aerobic culture, which is BACTEC plus with an extended incubation if necessary, a ZN staining and a linear probe assay LPA if smear positive, a TB culture using the MJIT and drug sensitivity, gene expert, always also a fungal smear and a fungal culture. Besides this, if anything else comes to my mind, brucellosis, whatever, you may add to it. But this is the way that we go about. And a very good take home from what Ranjit said, you can bill the patient initially for everything and return the money if you don't really need to go ahead. A sensible thought, and maybe we can all work on it. Please understand, the essence of TB management is anti-tuberculous therapy, rest and bracing. However, what then are the indications of surgery in active tuberculosis? Well, there is a classification which tells us that you may need to do surgeries, and what type of surgery that we need to do is where we'll begin, and then we'll put those surgeries where we need each one of them. This is a GATA classification which said that there are 3 different types of lesions. A is 1A and 1B, a single level disease where you could just do a biopsy and start drug therapy. An abscess where you could drain the abscess, do a local debrima with minimal access and treat the patient medically. A type 2 where there is a pathological collapse. However, there may or may not be a neurology and there may not be a sagittal deformity more than 20 degrees. So it's less than 20 degrees where you may get away with a limited stabilization. And there's the other side where you will have to do a complete anterior debridement, posterior debridement, or a posterior from anterior or an anterior from posterior decompression stabilization with an instrumented fusion. And finally, coming to that type 3, which is a grossly unstable, both neurologically and mechanically, where you will have a deformity which is more than 20 degrees or is coronally shifted as well, where you'll need either an anterior decompression stabilization, as a lot of us did in the initial part of our trainings, or now a posterior instrumented decompression and stabilization. You could access the anterior column from behind. So this is the way we look at it overall. Does really debridement and clearance remove the disease? Well, there is no real literature or evidence available to the efficacy of AKT more. However, cleaning that area up and putting fresh bone and adding and correction of any impending deformity adds to the well-being of the patient. And hence, a lot of these patients do feel better after you've cleaned them up and put in fresh, healthy bone graft with a healthy spacer and a support. So where are we? When you have neurological deficits in an acute or a non-acute onset with compression of the cord, yes, we need surgery. Where you have spinal instability with a deformity or a kyphosis more than 20 degrees or a kyphoscoliosis, yes, you need surgery. If there is no response to chemotherapy, despite the best of your efforts and whatever you've done, and there's no way that you can confirm that this is actually what was diagnosed as a typical TB is now probably turning its colors to a multi-drug resistant TB, which means non-response to chemotherapy, we may consider surgery. Repeated non-diagnostic biopsy, we may consider surgery. Large persistent abscesses are never an indication unless they are causing collateral damage. Let's say that they're causing some difficulty in breathing, difficulty in swallowing food. Yes, they may need something for the collateral damage prevention rather than for getting the neural decompression. So these are things that need to be looked at. When, why, and how? Well, one of the first papers that came out on this came from the KEM hospital in Mumbai, and it was supported, it was started there and then completed in the Hinduja hospital. Dr. Bhojraj and Jwalant Mehta came out with this paper, and they did a very simplistic thing. They tried to differentiate it between anterior and posterior part of the disease. Where there was an anterior collapse with mainly an anterior disease, they did anterior surgery. Where it was purely a posterior disease, they did a small posterior surgery. And where they had a combined disease, they usually did a posterior surgery, which went transpedicular and around the canal. They divided them into group A, B, C, and D. The D was just the posterior lesions, which is like a spinal tumor syndrome from behind, which they decompressed out, which did not need much of destabilization. However, a lot of innovation came from across the border, and many of us don't respect it because it came, unfortunately, from Pakistan. If you really read this paper, this is a paper where if we start working and thinking and evolving on it, there's a lot to learn. They have actually looked at everything that we need to look at, which is they have... ये पूरा कैसे आगे चला गया बेटा? आपका पूरा प्रेजेंटेशन लास्ट स्लाइड पे चला गया. रीस्टार्ट करिए. आपका पूरा प्रेजेंटेशन लास्ट स्लाइड पे चला गया. एंड हो गया स्लाइड. दोबारा खोलिए. आप सीधा लास्ट स्लाइड पे चले. Is where they looked at points given for history and points given for examination investigations. And they also gave a location coefficient. If the disease is thoracic, if the disease is thoracolumbar junctional, or if it's lumbar. And they used a very, very good algorithm or a calculation where they had points for history, which were added to the examination investigation points multiplied by the location coefficient. If you look at it, the location coefficient is highest in the thoracic spine. That means your chances of getting towards surgery are highest in the thoracic spine, followed by the thoracolumbar junction, followed by the lumbar spine. So just give it a thought. It was very well done. Have a look at this paper. And it is easy if you can actually start thinking in that direction. If it is less than 5, this score we give only anti-TB. If the score is 6 to 7, it is surgeon specific and institution specific. And if it's more than 8, you have to combine it with surgery for sure. So there is a gray zone given in between, and go through it. We've all evolved and used without knowledge of this, but if you want to document it, this is a good presentation. What surgeries do we do, and when do we do only anterior? When you have a lesion like this, which is mainly for pain or for biopsy or for both, you can go in transthoracic, purely thoracic, do a decompression and stabilization. This is now almost 15 to 18 years back when I should do these surgeries. I may probably today do only a posterior short segment or just an in situ stabilization if this patient needs a minimally invasive open decompression from behind. We combined back and front, where we did mainly back surgeries where the patient didn't have a significant kyphosis more than 20 degrees, but they needed neurological decompression. So a long posterior construct. Then we started doing back and front. I used to take separate incisions. I used to open from the rear. Then I opened transthoracic and put in this cage. Over a period of time, we evolved and learned to go around. Beta, aage nahi hil raha. We evolved going around. Aage nahi hil raha. बेटा मुझे मेरे हाथ में दे दो ना यार. तो हिल क्यों नहीं रहा? वही हुआ, पिछली बार भी वही हुआ. Or we can go to the front from the rear. So we've started doing, and most of us do that today, is that we do a posterior instrumentation, go posterolaterally, identify the thoracic nerve root, or if it's thoracolumbar, we are more careful, and then go and put in the cage from behind. This is the standard, which is the front from the back. We have now evolved to a further stage where we've tried to reduce the amount of gap in the front by doing a posterior shortening as well. So we've now gone from a stage where we did only front to only back to front and back to back with front added from the back. And now we are doing mainly back with the posterior shortening with an adequate decompression above and below, which is actually working extremely well today. You can correct all deformities, get adequate decompression. You need not necessarily put an anterior support if it is not necessary. So this is where we are. Well, there is a lot of evidence available in literature to support all these things which I've said and more. But today, the jury is still not out whether the patient really needs a surgery or how long we can wait with incomplete neurology. Because there are people who are still waiting with incomplete neurology on AKT. I am one of those. In the earliest neurology, I offer surgery to the patient. However, there are people who wait with incomplete neurology. And as I said, the jury is not out in this thoracic and thoracolumbar junctions. The evidence is that anterior radical debridement and reconstruction using titanium mesh cages is an acceptable surgical option for treatment of thoracic and thoracolumbar junctional TB. Solid bony fusion, good clinical outcomes, as well as improvement in neurological function can be achieved with appropriate selection of anterior instrumentations. Patients with even severe symptoms and those with presented late during the course of the disease have a good functional income. So please remember, a TB can be operated even late in the presence of neurology, and you can still be hopeful of a good outcome, comparable to those patients with mild symptoms and early presentation. Besides this, the anterior approach is favored method for debridement and decompression as the lesion is situated anteriorly. However, this is with increased morbidity because it's a transpleural approach. Posterior and posterolateral approaches give a reasonable access to the lateral and anterior aspects of the cord for an equally good decompression today. Better functional outcome and significantly better sagittal plane and kyphosis correction for the posterior approach are strong pointers for this approach. Lumbar spinal tuberculosis is a slightly different ball game. It can accommodate most of these, and a lot of lumbar spine can be treated non-surgically, except those which are getting kyphosis or a flat back. As you see, it's only patients like these with gross deformities who would need corrective surgeries more from pain and deformity point of view. Hence, in all these patients, there are absolute indications and relative indications. Absolute is where you don't know much about the disease and there is a significant progressive neurology. Relative is an incomplete deficit with persistent pain and instability. In my hands, this incomplete persistent neurological deficit has now moved from relative more towards absolute. Beta vapas atak raha hai. Okay, so this is where we are. This is the first where you're not sure of the diagnosis. Was this Cox or something else, where you will operate? Here again, this is not, and this is something which was done incompletely, inadequately many years back. I would probably not do this surgery today, but this is just to show you that we used to do a lot of anterior surgeries with small posterior corrections in the past. This is incomplete deficit, so it was done. Again, a lot of these surgeries are back and front surgeries. Approaches can be all back or they can be back and front. Finally, last two slides, what are the indications for surgery? Without neurology, progressive bony destruction despite AKT. So it's not the quantity of the disease, but the character of the disease which changes, which goes in multiple affections. Failure to respond to conservative therapy. Evacuation of paravertebral abscesses despite increased AKT causing a collateral damage. Uncertainty of diagnosis for biopsy. Mechanical instability due to destruction or collapse of 2+ vertebrae and kyphosis. Prevention of severe kyphosis in young children with extensive dorsal lesions. I have not alluded to it here in this presentation, but that is a part of the study. Large paraspinal abscesses which do not resolve despite the best of your treatment. I would do percutaneous just decompressions if they are causing any form of collateral damage. With neurology, new or worsening neurology, lack of improvement, paraplegia of rapid onset, late onset paraplegia, neural arch disease, painful paraplegia in the elderly, and spinal tumor syndrome where radiologically you don't see anything on the plain film. It's only an epidural tuberculoma which is picked up on an MRI with or without an osseous involvement. Finally, does doing this surgery eradicate the disease? No, it does not. Then why the hell do we operate when we have XDR, TDR, and MDR sitting on us? We do it because we believe that there is some hope. There is some light at the end of the day. We do it because we do not let the fruit be the purpose of our actions, so that we are not attached, not just to do our doing our duties. We have to do our duty, and we have to do it in these patients, hopeful that neurology will improve, howsoever rapid or late it may present to us in TB. A more pertinent question: can we, in this scenario today, eradicate TB before it eradicates us? It's the longest standing disease. Every time we think that we've overcome TB, it comes with something new and hits us harder. So as much as we may believe that TB is very easily treatable, please understand TB will always have an upper hand. Yet we live in the hope of a better tomorrow. And that's the reason why we still operate on tuberculosis of the spine. Thank you very much for a patient hearing.
Thank you, Ram, for this excellent talk. Any questions for Ram till the time I load the video there?
Dr. Mihir Bafut will be sharing a surgical video. If there are any questions on either my talk or any burning question related to any of the previous talks, till Mihir loads his slide, you can please come up with them.
I had to make sure that I catch the right patient, which is more than 1%, what Vishal had said. So this is a patient who has been treated for tuberculosis for about 6 months. And you can see that there is a big pseudoarthrosis gap after 6 months of AKT. And there is a frank instability. However, this patient had multiple medical problems. He had cirrhosis, he had glaucoma, he had a recent stroke, he had chronic kidney failure with dialysis, he had diabetes, he had hypertension, and he was on bed for 6 months. So we did not open this patient. The aim of this is to just show you the decompression part. The fixation of screws, I think, is a very standard procedure now. So we opted to put percutaneous screws because we did not want a great deal of morbidity for this patient. Soon we will go to the decompression part. All of us need to understand that in the thoracic spine, when we look at an AP X-ray, you will see that the canal occupies only the central portion, which is about 1.5 centimeters. And the rest of the disc or the foraminal area is actually out of the zone of the spinal cord. So here we are seen doing a D12 laminectomy. So now this is an ultrasonic scalpel. I have used this just to mark out the area of the lamina, that is where the spinal cord is going to be. So if you see this,
so
that's an area
this is the area of your cord.
What is on the either side of it
That's
is
your
actually
inferior
the facet
facet.
area and the pars.
The pars
The superior
and the
facet
superior
of the D12,
facet.
the inferior facet of the D12,
Okay, overlapped by
and
the inferior
pars
facet of the D11.
that is going to be
So your area of
working
work
area.
is there.
So the area of decompression is called as transfacetal decompression, which is outside the zone of the spinal cord. So if you see the working area, you are actually cutting it laterally. You are not coming towards the spinal cord. Now, after I'm showing this in particular way so that you understand the anatomy here. So first we have removed what we call as the pars of the D12. And that's the laminar portion, which we are going to just thin out so that it remains as a cover on the spinal cord, remains there as a paper thin lamina, which will protect all instruments being used in the lateral gutters. So that's the area. Now, if you see, the zone of decompression is outside the zone of that lamina. That's your pars area. So once you have deepened this,
the inferior facet has been dissected.
You have seen the superior facet of the L1. That's the foramen of the D12.
The D12 and the L1. That's the L1, L2 part.
That's the foramen.
That's the pedicle.
That's the pedicle area of the D12 now, because
Of the D12. The part and the pedicle.
So you
That's
see,
the
you're
superior
creating a
facet
gutter and you are actually going
of the
outside the
D12.
canal. You are removing the inferior
After
facet
the inferior facet has been
of the
dissected.
D11 to reach the superior
the
facet
the canal.
of the D12. Now that's the area
So
of
this
your
whole area
So that's
is
your
the
rectangle window through which
transfascial
you are going to approach
area.
that body.
Wow.
And your trajectory is going to widen more on the lateral side. So you are going to take out your lateral side of the body, you're going to take out the medial part of the rib and create a trajectory that angle towards the center. Now you see how I'm working outside the spinal canal by just thinning the medial wall of the pedicle. The medial wall of the pedicle is still intact, and you are just creating a shell which moves like this around your spinal cord. Now create your gutter on the lateral side. See, it keeps widening on the lateral side. Your spinal cord is still not exposed. You have created a complete gutter. There's hardly any bone loss doing this. Hardly any blood loss doing this. You are deepening it down into the body, but your spinal cord is still not exposed. This is how it looks after your gutters are deepened. Now see how the shell of the lamina can be removed. You see how it is peeling off the spinal cord. It is really paper thin, and you are actually decompressing the spinal cord with no introduction of instruments inside the spinal canal. So once you have broken the upper end of the lamina, the whole flap will open on the lateral side like this. The pedicle has already come out. You will see a thin wall of the pedicle. So pack a patty into the foramen of the D11 there, so that you stop the oozing from the epidurals coming from there. It will stop the oozing. That's the thin wall of the pedicle that is left. All this was done before you started peeling off. So your instruments actually never touch your spinal cord. The next step is to identify your D12 root, because the D12 root is going to come in your way. So here you are removing the medial encroaching part of your L1 facet. So once that goes off, you see your D12 root. On the top of that, you isolate your D12 root and tie it off. So once you have tied your D12 root, now there is nothing that is going to stop you from entering the vertebral body. And it's a huge space. That means you don't have to be constrained about the space. Segment, use a lot of bipolar to coagulate whatever bleeders you get from under the root. And now that's your area of working. So that's the remnant of the pedicle wall which is attached to the body. And then you are now cutting the deceased body with a knife. So once you enter from there, see, there's hardly any retractor required. The cord is just lying there. You just open up more and more on the lateral side. So this is now cutting out the lateral wall and the medial wall of the pedicle, medial wall of the rib. So now that's under the spinal cord. So you are separating the under surface of your destroyed body from the spinal cord. The next step is to just hammer it down. You can push it down with a very gentle force. So all your sequestra and your granulation tissue will start separating from the ventral surface of your spinal cord. And this you can actually go right across the midline. So you see the trajectory of the instrument, it's working towards the midline now. So go more lateral. If you feel that you're not able to approach the midline, you can go more and more lateral, create more and more medial trajectory. So whatever it takes to position your cage right in the center of the body, you have to go that far lateral. So that's measuring the cage there. First, you have to put the cage straight down between your pedicles. It goes straight down. And then you have to shift it with an instrument towards the midline. Unfortunately, that shift I could not show because my hands were coming in the middle. So that's the cage in between. The cage is already shifted. You can see that where you saw the cage, now I'm packing the bone graft. So the cage has already been moved towards the midline, and that's the position of the cage. Bang in the center through a facetal approach. Then you put your screws and you stabilize the spine, compress the screws and get a stable situation. Thank you.
Thank you, Mir, for a fantastic presentation.
Sir, how do we put the cage in lower lumbar spine? Because there we cannot sacrifice the roots.
No, you can't sacrifice the root, but actually the lower roots can be mobilized. That means that if you free them far lateral, you have really resected your parts and you have a good segment of the root. This root can be actually mobilized up and down. So you have to have one assistant protecting your nerve root retractors. Now there are different ways of putting a cage. Some people tie a vicryl thread on one side, insert it inside, and then pull the vicryl cage, pull the vicryl thread on one side to get the cage inside. So there are different ways, but once you have the root under control, you can actually position the cage and shift it. But it's not such a difficult task to do it even in the lumbar spine because the roots are mobile.
For the ease of insertion, do you ever have to make transverse incision to medialize?
Transverse?
Like a T.
You can extend it. He has done it very nicely because.
So what I tried to show here is that
like a T.
The direction of your instrument will be decided on how far lateral you go. So the more lateral you go, you are angling towards the midline. So that depends upon your approach. In thin patients, you don't have to resect that far lateral. In thick patients, you really have to use retractors, pull and go far lateral because you really can't pull your neural elements beyond a certain extent. So you have to stay away from your neural elements, handle them minimally, and create a lateral channel so that you actually go through the lateral channel into the center of the body.
Thank you, Mir. Thank you very much. Vishal and Mir, any panel discussion or final case presentation? Summary statement. Yeah.
Any questions on TV or medical or surgical?
Any questions?
Yeah. So I think TB is still a sort of an enigma for us, and it's going to keep challenging us all through. What we have to realize that it's a medical disease. The medical principles of treatment have to be followed very, very strictly. And a surgeon comes into play only when a patient deviates from a standard pattern of response. So when the patient shows an abnormal response in terms of structural instability, the surgeon comes into play. Till that time, it continues to be a medical disease. And in our country, we have a relative acceptance for a moderate kind of deformity, which we have seen that doesn't affect the function for a long time. So don't try to be overzealous in putting screws for very, very mild deformities because you just want to operate. So that's extending the indications, and let nature heal the disease. That's the best bet for the patient. Thank you.
Thank you very much, Mir. That was fantastic. Couple of points that I have learned, and this is not evidence-based, but purely experience-based. If you've had a patient who has done extremely well, either non-surgically or surgically, has had a reasonable period of good quality life, maybe 5 years, 10 years, 15 years, and comes back to you later with similar pain, and then you image, and you now see suspicious diseases, please do a rebiopsy. And don't be surprised. I have had more than 3 or 4 patients who were done well with typical 4-drug regime, and it was a closed chapter. But TB never really heals. It only remains quiescent. It can wake up even after a decade. it can skip another level and it may turn out to be multi-drug resistant TB. And the other thing also, you remember that multi-drug resistant TB actually fights your bony healing to a large extent. So your surgery for in a multi-drug resistant TB has to be far more aggressive, far more complete, and far more solid with a lot of metal work. Because MDR COX itself is a different animal as compared to typical TB. And typical TB is very, very polite to implants, and it is not too bad with the implants. But MDR TB is not very polite with implants, and you have to be very, very careful. So this is just in that handful of cases where I've had to go in 5 years, 10 years down the line, all of which turned out to be MDR, and all of them that had extensions of the surgery, like an adjacent segment disease, and I had to go above or below, and at times even both.
Thank you, sir. Thank you, Dr. Ram. I think this is time to change the gears. Just a small announcement. We have inauguration ceremony going to start in 15 minutes from now in Hall A. So if anybody wants to attend the inauguration function, please move on to the bigger hall, Hall A. Here we are going to change our gears and move on from diseases to non-disease geriatric spine, and nothing worse that can happen to any of our spine problems than addition of osteoporosis to it. So we are starting with our session on osteoporosis. Thank you, panelists. Thank you, chairperson, for joining us for this session. We are going to be moving on to a session, and may I call upon our next panelist, Dr. Chirayu Pamecha, who will be the moderator with me, and may I call upon our panelists, Dr. Amit Jhala, Dr. Ranjit Unnikrishnan, and Dr. Lalit Sharma to please chair the dais, please. Dr. Lalit, Dr. Ranjit, and Dr. Chirayu, Dr. Amit Jhala, please, on the dais, please. Yeah. May I call upon Dr. Tarun Dusad, who's going to be presenting us with the dilemmas about what problems can osteoporotic fractures pose to a spine specialist dealing with problems here.
Good evening, all. Let me quickly put a case here. A 65-year-old male presented with trivial fall. He had mid-back pain. He was diabetic, hypertensive, a history of brain stroke 5 years back. There was no leg pain, and there was no bowel bladder disturbance. This was his X-ray at 1 week, and we suggested rest and pain management. After 4 weeks, the collapse in the vertebra increased, and this was the MRI at 4 weeks. So to summarize, we have certain questions which come up with this case. Is this osteoporotic fracture or something else? And what will be your plan of action at 1 week or at 4 weeks? How would you manage it medically? The role of bisphosphonates, teriparatide, denosumab, calcitonin. What will you choose? Vertebroplasty, kyphoplasty? If there is associated neurological deficit, then you'll choose vertebroplasty or something else. What are the surgical principles to treat this case? And I'm sure that our symposium will answer all of these questions. Let's go through that symposium quickly.
Thank you, Dr. May I call upon Lalit? Lalit is going to be helping us to understand if these fractures that are seen on MRI as benign osteoporotic fractures turn out to be osteoporotic fractures always, or there is something hidden there to change the overall climax. Over to you, Lalit.
Thank you, Vishal. So it's a very common presentation which Tarun just now has given a case. So an elderly male or female presenting with back pain, and on X-ray we find a vertebral compression fracture. So these vertebral fractures can be simply osteoporotic or they can be pathological. Now this makes a hell lot of difference in evaluating these patients and managing them and giving a good outcome. The osteoporosis can be senile, postmenopausal or secondary. The pathological can be either neoplastic or infective or metabolic. So broadly we have to see whether it's osteoporotic, neoplastic, pathological, or infective pathological or metabolic pathological. So our entire approach to these patients should be concentrated on identifying those patients who are presenting with a pathological fracture. And how to do that? So how to identify which patient is benign osteoporotic fracture or which patient is a pathological osteoporotic pathological fracture? So the first and foremost thing is history. Then we have to look for lab parameters, and then we have to go for appropriate imaging as per these history and lab parameters. So history, if the patient is presenting to us with very minimal trauma, it's a atraumatic onset or a very low energy trauma, then we should be suspicious about it. The hallmark of pathological VCF is rest pain. So if the pain is worse at night, if the patient is complaining that he or she is unable to sleep at night, we have to raise our degree of suspicion. It may be exacerbated by movement, and the pain actually in most of the common osteoporotic vertebral compression fractures, the pain gradually subsides. While in pathological fractures, the pain will gradually and progressively will be worsening. And pain at multiple locations may suggest a non-contiguous metastasis or something like that. Any history of malignancy in past, patients usually hide this. They are scared of telling the name of cancer from their mouth. So we have to be very specifically ask them if they have had any malignancy in the past. A malignancy 5 years, 7 years, 10 years in past also may present now as metastasis. Constitutional symptoms are very, very important. Weight loss, loss of appetite, and fever may indicate either neoplastic or infective pathology. Other systems, symptoms of other systems like hematemesis, hemopsis, a vaginal bleed, prostatic symptoms, melena, hematuria should also be looked for, because these might also give us some indication about the pathology. Any history of previous fractures may suggest osteoporosis, and family history we have to look for if there is any significant family history of malignancies or osteoporosis also. Examination, general physical examination is also very, very important. Like a simple pallor may indicate underlying multiple myeloma. Icterus may indicate underlying liver metastasis. A septic look may give us an indication about infective vertebral compression fractures. Severe paraspinal spasm and major neurological deficits are usually not seen with benign osteoporotic fractures. So these should also raise our suspicion for pathology. X-rays are very, very useful tools. We can see about sagittal alignment, spinal alignments in different planes. We have to see about bone quality, the degree of collapse, the presence or absence of cleft, and the presence of posterior elements involvement. So a winking owl sign can be a pathognomonic of metastasis, presence of instability. And we also should never forget about other X-rays like chest X-ray. A patient presenting with vertebral compression fracture and chest X-ray showing cannonball would make the diagnosis very, very obvious that it's metastasis. So by X-ray and by X-ray lab parameters and imaging, we should be able to identify most of our patients who need further imaging like MRI or CT. Whenever we are in doubt, MRI is the modality, screening modality of choice for differentiating these fractures, because there are many, many features between benign and pathological fractures, which can tell us about their origin. So benign vertebral compression fractures are usually wedge-shaped or biconcave, while pathological vertebral compression fractures are either usually crush fractures. Benign vertebral compression fractures usually have a fracture line. So benign vertebral compression fractures usually have a fracture line which can be seen as trabecular impaction, and it is usually parallel to the end plates. Usually it's very close to the upper end plate. There is usually sparing of normal T1 marrow in vertebral in osteoporotic vertebra, like we can see in this. Do we have pointers? No, it's okay. So in benign fractures, we see there is a normal marrow in both T1 and T2, while in pathological fractures, in most of the cases, the entire marrow of that vertebra is involved. There is a biconcave, there is a concave convex posterior border. Okay, thank you. So a convex posterior border, involvement of whole of the vertebral body, absence of any vacuum cleft are signs indicative of pathological. So vacuum cleft is usually present in benign vertebral compression fractures. It is absent in pathological. Sparing of T1 marrow, posterior involvement, posterior elements of, if they are involved, then it is almost sure that we are dealing with something which is pathological. Presence of other old healed compression fractures makes it highly suggestive for a benign disease. So MRI is very, very useful. This is a radiology of what we call a fluid cleft or Kummel's disease. So if we see on X-ray, there is this cleft-like thing which is seen on X-ray. We can see this vacuum sign on MRI, and we can see this fluid cleft on which is hyperintense of T2 and hyperintense on T2. I don't have a T1 image on MRI. So this pattern with relatively normal marrow appearance of remaining vertebral body is highly suggestive of a benign vertebral compression fracture. This we have already discussed. Retropulsion of vertebral body, burst type of fracture is again suggestive of benign vertebral compression fracture. PET-CT can be used for differentiating and particularly looking for metastatic disease if we want to know about the primary. Now coming to few cases, like this 68-year-old female presented with mid-back pain for 6 months, no history of trauma, no history of constitutional symptoms. She presented with tenderness over T12 with upper motor neuron signs in lower limbs. This was the appearance. This was a known healing vertebral compression fracture, which was benign, but we, as patient was having neurological deficit, we decided to fix it. This was the MRI. And we fixed it with the cement augmented screws. The biopsy revealed normal, no pathology. Another patient. This patient is a chronic pulmonary case where she's having ILD basically, and she's on long-term steroids. So she's having steroid-induced osteoporosis, and now she presented with the fracture of L4 and L5 vertebral bodies. So L5 was also having a fluid cleft in it. So this was done with simple cement augmentation of the vertebral bodies. This is a very, very interesting case because this female presented to us with constitutional symptoms and progressive neurological deficit, and this was the MRI. Now I don't have her previous MRI. She actually had this fracture, which actually turned into vertebra plana 4 years ago. So the MRI after healing did not reveal anything. And this vertebra plana developed after a very, very trivial injury. So in a 40, so she was 48 now. So 5 years ago, she was 43. So if at age of 43, if she developed vertebra plana with a trivial injury, it should have raised suspicion at that time, but it was simply treated as osteoporosis at that time. And after 5 years, she presented with this. So we operated on her, fixed her, and the biopsy revealed plasma cell tumor. So the tumor actually was growing 4 years, 5 years ago. So we have to be very, very suspicious about all these things. Again, this is a very good case. This patient presented with sudden onset paraplegia, and the MRI revealed multiple level disease. So again, this type of picture, we are very, very clear that we are not dealing with anything benign. So this patient was investigated and came out with gastric malignancy. This 57-year-old male presented with low back pain with right hip pain from last 3 months, and his hip rotations were normal. He was neurologically intact, but was not able to walk. He was investigated elsewhere, where all the investigations were done. The MRI revealed a lesion in C4 and L5. And this patient was sent for PET-CT. The PET-CT was reported as multifocal bony metastasis. So this is, I have highlighted this case to tell you that we have to be very, very judicious about selecting our investigations, because wrong investigations can put us on a wrong path. When we see this patient, the diagnosis was there in this plain X-ray. So when we saw this X-ray, we advised for a skull X-ray and a hand X-ray. And the diagnosis was very, very clear that we are having a salt and pepper type of skull here. So we advised for PTH, which came out at more than 3000, hypercalcemia, calcium was more than 12. And the patient was then put on neck ultrasound, which revealed a adenoma of parathyroid gland. And now he's undergoing surgery for that. So it was not a metastatic disease, it was a metabolic disease. So a wrong investigation can be interpreted wrongly. So all the investigations should be put to rigorous clinical test. So we have to be very, very obvious, very, very clear before ordering any investigation, what we are suspecting, what we are expecting from this test, and how we are going to interpret it. So take home messages: vertebral compression fractures are common. Most of these are benign but can be pathological. Detailed workup is very, very essential. And history, lab, imaging, including plain X-ray, everything has a significant role in finding out the cause. Thank you very much.
Yeah, I think that's an excellent talk, Lalit. Just one question. What's your take on bone scan? How often do you use it? Or you rely more on the PET CT?
Nowadays, if I'm suspecting metastasis, I go for PET CT.
Okay. And otherwise, for a vertebral compression fracture or a non-union, do you ever use bone scan or dynamic X-rays or anything like that?
Dynamic X-rays, yes. I very rarely use bone scan. I use X-rays, and MRI actually gives most of the information which we need.
Fair enough. Shall we go ahead? Okay. Nice one.
Thank you.
Yeah. Vishal, I think Dr. Vishal is going to speak about medical management of osteoporosis.
I think Lalit has set the ground that osteoporotic fractures have to be diagnosed first before treating it. And then, as rightly mentioned, that unless and until your first foot is strong, you should not take your second foot, which is medical management. And as has been highlighted, that osteoporotic fractures in most of the cases would really respond extremely wonderfully to medical management if they are diagnosed well and treated well. Just to highlight the case that Lalit mentioned, a case scenario here: 68, female, obese, diabetic, and has a minus 3.1 DEXA 6 months ago, had a trivial fall in bathroom, got an X-ray and MRI done. The son is a quite educated guy. And that's the kind of X-ray MRI comes to your clinic. Chirai, what runs into your mind here? What are we dealing with, and what should be the next plan of action?
I think it's like osteoporotic fracture only.
That's right. That's right. Yeah. So Girish, what would you do? It's an osteoporotic fracture, and what should we do? It's 3 days old fracture. Patient is in terrible pain, trivial fall. So what is our next line of management? Vertebroplasty, yes. Tarun, would you do something differently? Vertebroplasty is one option, yes.
Not at the 3 days of duration within injury.
Yeah. So what's your next plan? Patient is in terrible pain.
Yeah, I will put the patient on rest. I will treat the pain conservatively, follow the patient closely.
Right.
Within 3 or 4 weeks.
Wonderful. So that's one way of wait and watch policy. Dr. Amit, anything new that you would do? On one side, we have one who's waiting. Another side, we have someone who wants to take care of the pain first.
We can just get the investigations done just to rule out other pathologies and then treat them.
That's the baseline. I think nothing else could highlight the importance of what Lalit just spoke about, that diagnosing an osteoporotic fracture is the most important thing. And unfortunately, in this patient, despite the best of treatment, what Tarun followed, this patient failed over a period of time. And if this patient had followed the treatment of Girish also, he would have failed miserably. So on one hand, Tarun has failed, but he is still not burned all the bridges. On the other hand, if Girish had did a vertebroplasty, we would have probably jumped our bridges and would have did a disaster in this, because this patient again turned out to be multiple myeloma and nothing would have helped. And the message is that all collapsed vertebrae that happen in 60 plus year of females or known osteoporotic patients, even when you have a trivial osteoporotic looking fracture, do not jump on them, because most of these happened in 70 plus females and none of them was osteoporotic. Why? What I'm trying to tell you is that osteoporotic fractures are a diagnosis of exclusion. They are not your primary diagnosis. Even if a fracture happens in a post-menopausal known osteoporotic, please have a high index of suspicion. Remember, METs happen in elderly, myelomas happen in elderly, even plasmacytomas happen in 50 plus, and there are a hell lot of problems that create pathological fractures. And pathological fracture is a definition where a trivial fall results into a wedge compression fracture without a soft tissue injury or soft tissue abscess. And these trivial fall related fractures are termed pathological fractures unless proven otherwise. So next time a lady walks into your clinic with a wedge compression fracture, don't jump to osteoporotic treatment right away. Of course, it's your duty to treat pain. It's your duty to initiate osteoporotic treatment. It's your duty to counsel the patient and sensitize them about osteoporosis. However, it's also your duty to rule out, because this is the time, this is the opportunity to find out if this fracture that has come across you is a myeloma or not. Have you ruled out hyperparathyroidism? Have you ruled out osteomalacia? Have you ruled out severe osteoporosis? Have you ruled out any infection? And of course, TB is something that is extremely common in this age group, even in patients who have well-established osteoporosis. So the approach to every collapsed vertebrae in my books today is baseline lab profile. Like what Tarun mentioned, I would surely manage pain, give them bed rest, wait and watch, observe pain over a couple of weeks time. And if the pain is progressive, surely all these investigations come into picture. A myeloma profile, bone scan if the pain is persistently increasing, tumor markers if the patient's symptoms are progressively increasing, and surely a CT guided biopsy if my MRI shows even slightest hint of something suspicious. So rule number one, all elderly with fractures have osteoporosis, but all fractures in elderly are not osteoporotic fractures. Osteoporotic fractures do heal by themselves, and that is why wait and watch is still a game to play. So now here we have an osteoporotic fracture. Now we know that this is an osteoporotic fracture. We have ruled out myeloma profile is normal. Everything is okay. What is the rule number 2 here in this patient? We all know that 81% of these fractures heal quite well. And this healing happens irrespective of whether you treat them well or not, irrespective of whether you give them medical management or not. Medical management of osteoporosis primarily not only meant to heal these fractures, but it is primarily meant to prevent secondary fractures coming to these patients. It is not only meant to take care of pain for these patients, but also meant to prevent secondary fractures. So if a fracture is supposed to heal, it will surely heal over a period of time, like it happens in 81% of patients. And it happens primarily by this rather than by medication. And so the first rule of medical management in every osteoporotic patient is improve their nitrogen balance, bring their protein content high. Bone being soft is not only calcium low. Bone being soft is not only vitamin deficiency. Bone being soft means it is the protein matrix of the bone which has gone down, and that is why it is your duty to bring out the protein matrix up and giving high protein diet, improving their muscle tone. Remember, osteopenia is the extreme of what we call sarcopenia. So a patient who's got an osteoporotic fracture has also got muscle mass wasting, and we should build up not only muscle mass but also protein mass, and that requires high protein diet and general care. And we all tend to forget one thing, that the most effective way to prevent a secondary fracture from happening is not all the bisphosphonates or teriparatides or alendronates or any kind of drug that is available in the market, but it is prevention of fall modalities. 90% of these patients will have one secondary fracture within 5 years of time if you don't follow the prevention of fall modalities, which involve adequate lighting at home, avoid carpets at home, keep their bathrooms dry, having a small bulb lit up in their bathrooms will really prevent hip fractures, radius fractures, and shoulder fractures as secondary fractures happening in these patients. This is something that we must emphasize to all our patients. In fact, all patients in my clinic get this kind of printed sheet to the relatives that have you got grabbers in your bathroom? Have you got a dry bathroom? Have you got a light there? Have you got a bed switch for the patient so that at night they don't get in darkness and try to find a switch to lit up their light? So these are small things which can prevent secondary fractures in these patients, and we must pay attention to this. Once you pay attention to this, that's when the drugs comes into picture. So when to start, what to start? The problem is of plenty. There are anti-resorptives of various types. There are anabolic agents nowadays. There are teriparatide. There are hormonal therapies. And there are so many other combination under development drugs also, which more than giving you knowledge, rather confuse you. Let me just summarize of what endocrinologists today follow and what is the consensus treatment today. Like I mentioned, best fracture prevention option is general care. Build up their muscle tone, build up the bone mass so that even if they fall, they can tolerate the stress well and prevent falls. That's the most important thing. And 90% of fractures in multiple studies have been proven that some houses where prevention of fall modalities have been implicated, they have lesser number of fractures by up to 70% than those houses where it is not. Vitamin C and vitamin D and calcium supplement is something that we all know, and this is something that we don't want to discuss here in detail. Now, second thing is, don't wait for fracture to happen. Start anti-osteoporotic treatment at the earliest. By the time anti-osteoporotic treatment is started, it's already late in our country. Whereas females, the first exposure happens with simple back pain, simple calf pain, knee pain. And so use this opportunity to diagnose them into osteoporosis or sarcopenia and start anti-osteoporotic treatment at the earliest. And this can easily be diagnosed by clinical pictures and also DEXA scan and BMD scan and various other measures. There are simple risk factor FRAX analysis where even before a fracture happens, you can actually start medication in the form of bisphosphonates, alendronates, or various other modalities that are available to your hand. Now, remember, anti-osteoporotic medication in the form of drugs, bisphosphonates or teriparatide or alendronates, or for that matter, the newer molecules like denosumabs, there is no empirical treatment permitted. You got to do a baseline workup. So even before you start alendronates, bisphosphonates, you have to do a baseline workup. Remember, all these medicines are known to create hypocalcemia, and all these patients already have low calcium levels. So you have to ensure that before you start bisphosphonates, teriparatide or denosumab, you have to ensure that the calcium levels are proper, their parathyroid hormone is at a neutral level. Imagine a situation where a patients have hypocalcemia resulting into hyperparathyroidism, and you are giving them teriparatide. You are creating a disaster for them. And that is why a baseline alkaline phosphatase, serum calcium, creatinine level is extremely important. Patients with high creatinine, even borderline creatinine, bisphosphonates and teriparatide is strictly a no-no in these patients. So a feasibility of use of these anti-resorptives is extremely important before you start medical management in them. Remember, frequent follow-up is very important, because all these patients whom you give either zoledronic acids in the form of injectable or oral bisphosphonates, they will have a tendency to have their calciums going down. And it's our duty to build up their calcium and stop bisphosphonates the moment you see hypocalcemia coming across in your frequent follow-up. Number 4, the first line of treatment is always anti-resorptives. You cannot just jump onto teriparatide on day one. You got to not only bring up protein levels up, calcium levels up, vitamin D restocked into them, started on some primary exercise, and that's when teriparatide comes in, only when you have ensured that the parathyroid hormones are in neutral range, not on a higher side. Alkaline phosphatase or bone turnover is not on a higher side but on a lower side, because teriparatide can actually lead to increased bone turnover. And if you have any of these parameters higher, you are probably going to create disaster. And that is why the first line of anti-osteoporotic treatment is anti-resorptives in the form of bisphosphonates of any type. It can be injectable or oral, but start with weekly, monthly, or anything that is most compliant to these patients. And the options are 2 of them. It can be either bisphosphonates or the newer molecule, which is denosumab, that can be given in subcutaneous forms. I generally tend to use denosumab as a maintenance therapy rather than initiation therapy. So you tend to use bisphosphonates for 2 years, and then at the end of 2 years, when you have burnt your bridges of oral bisphosphonates, that's when denosumab takes over. Now, what do bisphosphonates do? They prevent bone resorption. And remember, do not use them in acute fractures. For early 2 weeks, it is asked not to use bisphosphonates, because bisphosphonates in the first 3 weeks, they actually increase bone resorption before they start preventing bone resorption. That is why not to use in acute fractures. They are known to create more pseudoarthrosis. Non-union rates are very high, particularly in hip fractures. It is known to create so, and that is why should not be used in acute fractures. Should not be used in young patients. You will be burning their bridges pretty early. Check the feasibility of use. Always check calcium, creat, and PTS levels before you start them, and avoid using them in patients who are on pantoprazole for chronic term. They are on steroids, or for patients who are asthmatic, you may be actually creating far bigger problem than preventing them. And that is why checking the feasibility of use of these medicine is extremely important. Otherwise, there are problems like jaw problems happening. Patients with low creatinine levels can have avascular necrosis of the jaw with even oral bisphosphonates happening, and this is something that is very important. Now, once you have burned down this, you have used 2 years of bisphosphonates. That's when the newer anti-resorptive mechanism like denosumab comes in. These are subcutaneous injections, and I generally tend to have a combination. When my orals cannot come in, that's when the denosumab comes in, or when I have burnt out oral picture, then that's when the denosumab comes into picture. Now, how do they work? They just increase bone density by preventing bone resorption, and they have maximum efficacy on hip fractures, but also on spine. They prevent secondary or adjacent level fracture happening in these patients. And teriparatide is something that's like a boon. And now I have started that in 3 weeks time when the anti-resorptives have started. So early 2 weeks pain management and salmon calcitonin to prevent pain in these patients, followed by 3 to 4 weeks of anti-resorptives, and that's when teriparatide comes into picture. Remember, a fracture happening to an osteoporotic patient is in itself an indication that it's a severe osteoporosis. You do not have to depend or rely on only BMD scores to say that teriparatide is a drug to be used in severe osteoporosis. No, that's not true, because any fracture is direct indication that the osteoporosis is severe enough, demanding for an anabolic agent if it is feasible to use in. And that's why don't solely rely upon BMD measures. If there is a fracture, he is a straightforward candidate for an anabolic agent like teriparatide, provided provided the patient is fit enough to receive anabolic treatment. How long can you give it? Ideally for minimum 18 months, ideally for 24 months. However, again, it's a bone turnover marker, and that is why every 3 months you must check the calcium levels, alkaline phosphatase levels, and ideally urine bone turnover markers, so that you are not looking at results of hyperparathyroidism in these patients, particularly in patients who have low creatinine clearance. And it is said that it is dose dependent, and that is why a combination therapy is something that is more in vague rather than single therapy. So how do we start with, and when to start? Asymptomatic patients who come to your clinic, start now. Start yesterday. Don't wait for tomorrow to come. Patients with fracture, always do a combination therapy, and maintenance therapy when you have burned bridges for 2 years. Denosumab every 6 monthly is something apart from the general care that we discussed, which is the most important aspect in prevention of fracture. How long do we give? Lifelong. Once osteoporotic is osteoporotic forever, and that's why start early, continue treatment forever. And this treatment may not always be medical, it can be physical. Developing muscle mass is the first treatment of osteoporosis, and that is why weight training, exercises, sunlight exposure, all these things are very important. When it comes to medical measures, of course, bisphosphonates for not more than 24 months. Denosumab has shown efficacy up to 60 months, and 24 months for teriparatide is something that is recommended. How do we monitor? We just discussed about it. Calcium, PTH, and alkaline phosphatase is something that at least every 3 monthly you must check to prevent any problems that may come up to you. And BMD ideally in 2 years, if preferably we can do it in yearly measures. That's very important. Now, why is it important to check BMD every yearly? Because it not only helps you to determine whether the patient is improving, but also tells you about the failure of the regime that you are following. If a patient is on regime, what you are following, and still BMD is progressing, today it is minus 2.5 or minus 3.5, and in a year's time, despite teriparatide, despite all my medication, patients, the BMD is not improving, rather worsening. That's when you know that there is time to change therapy. And remember, we as orthopedicians know only 3 drugs: bisphosphonates, denosumab, and teriparatide, but there are plenty of 10 other drugs like strontium, estrogen receptor modulators, and various other modulators that are available for treatment of osteoporosis. And this can easily happen in patients with early imminent renal failure, and that is why this is the time that every 2 yearly minimum, ideally every year, BMD should be done to check if your therapy is working. Even if it is status quo, it is working. But if it has degraded over 1 year's time, that you know that your therapy is not working and you would want to change therapy, ideally change lifestyle modalities. You know that there is some hidden factor which is preventing these medications from working. So the message is medical management of osteoporosis. There is no role of empirical. However, you got to start it yesterday in patients who are even asymptomatic, catch them by the risk factors, follow certain rules, both for initiating, monitoring, check the response, and maintenance doses are important, and also see if the fractures are healing well. General care and follow-up prevention is the most important thing to prevent secondary fractures there. Thank you so much. Any questions?
I think you'll have to give a recording of this talk to grasp a message out of it. Yeah, but
yes, it can be. It can be.
Some studies have said it can be combined with denosumab, but not with
No, so what I just spoken is that combination therapy is the best therapy, and combination necessarily doesn't have to be only orals with teriparatide. It can be with any form of bisphosphonate. Zoledronic, the problem with zoledronic is that it is an acute injection of the injectable there, and that can sometimes lead to avascular necrosis of the jaw and avascular necrosis of other areas. So that is something that is not recommended in patients who have sustained fractures, or in patients who have had medical issues. Oral therapies, that is why recommended, because it makes and ensures compliance there.
Vishal, one question I have is that sometimes it is difficult to know whether it's an acute fracture. Most of these patients have symptoms for quite some time. So I would actually start teriparatide very early and not start with bisphosphonates if I'm dealing with severe osteoporosis.
Very true.
Yeah.
Like I mentioned.
So
all patients, as I said, you can start teriparatide today, now, provided the feasibility check for use of this medicine is done.
Yes.
If the calcium levels are good,
then.
if the parathyroid is normal, creatine clearance is good, patient has sustained this, you can surely start teriparatide. Because the only clause or caution with teriparatide is that it can lead to rapid hypocalcemia in patients who are bedridden. So that is one check that you must ensure. 2, can we ensure that these fractures are acute or not? We can easily ensure. The MRI will tell you.
I know that, but then sometimes they just have a non-union which has been going on, the pain going on. That's why I said that for someone who's severely osteoporotic, I think instead of waiting, we can start teriparatide.
3 weeks waiting?
Fair enough.
I mean, you may want to build up more protein and calcium. It's still worth it, because teriparatide per se has zero analgesic effects. Zero analgesic effects. The only analgesic effect of any anti-osteoporotic medication comes from only salmon calcitonin.
Yeah, calcitonin is one.
The evidence suggests that bisphosphonates should be the first line of therapy in management of any osteoporosis. What is your take on the duration of osteoporosis, bisphosphonate with regard to the bisphosphonates use? Because you see nowadays, with the literature is saying there is a terrific increase in the number of atypical fractures, femoral fractures. So there is a concept of drug holiday which is coming up.
That's right. Yeah.
And this is especially true for bisphosphonates.
That's right.
So a message should go from this forum that they should not be used indiscriminately. Even there are reservations that as per your slide, it shows that the duration can be continued for as long as 5 years.
That's
but evidence has started showing that they have to be discontinued in between. They have to be taken up with other kinds of therapies if it's a severe osteoporosis.
Very interesting
where you see bisphosphonates have to be continued, but another alternative has to be taken up.
So very interesting question and a comment there. And in fact, if you saw some of my slides, like Dr. Chirayu mentioned, that there are so many messages that to summarize them, it will be really difficult in 10 minutes time. But on this question, the summary is that it is safe to use bisphosphonates in patients who are fit to take it, number one. Number two, bisphosphonates ideally should be given in combination therapy so that you don't have to use them for a longer period of time. Ideally should not be used more than 24 months. Unfortunately, with the geriatric population growing, young patients becoming osteoporotic, you'll have to start early bisphosphonates. So you will only be able to use them for 2 years to begin with. 4, in use of combination therapy, you may not want to use for a longer period of time. However, in elderly patients, you can also use up to 5 years. That doesn't necessarily mean that all patients should take it for 5 years. If you're taking combination therapy, you can use it for 2 years and then go on maintenance therapy with denosumab. That's what my recommendation is. Yes. So 2 years this and then denosumab.
3 months of teriparatide, then I use 3 months of bisphosphonate, 3 months of teriparatide. So that is.
I'm not sure of that, but then what I have read.
No, I think Ranjit, no, that's not the message you should convey. No, teriparatide, if it is given, so you know there is a dose. I think I'll just summarize this.
Teriparatide has an antibody thing.
Yes.
So you
teriparatide is one medicine. Teriparatide has a direct dose-related effect on bone density, and it is pulse dosages. The moment the pulse dosing comes down, the effect goes down. So if you take a break after 3 months, whatever you have built up bone will surely go down. And that is why continuation therapy is extremely important, number one. Number two, nowadays, in fact, what people are working is rather than to have any drug interval, how do we prolong the use of teriparatide? Because it can be given only for a certain number of months. So now there is this concept of, yes, now there is pulsed, 2 years in lifetime. So now there is this concept which is evolving. There is research going on, alternate day pulse dosages. Alternate day pulse dosage of teriparatide.
This therapy has been studied. Cosman paper is there. It was done you cannot use for the 24 months in patient's lifetime. So what you use to decrease the cost and keep a reserve, you use continuous therapy with alternate bisphosphonate. The bone density is say 93% of what you get as giving daily doses.
Yeah, I think it's interesting. It will be interesting to go through this paper. But as of now, we in this forum, where so many guys will be watching us in peripheries, this medicine will be used rampantly. It is already rampantly misused. Rather than used, I would say that both these medicines are misused. The problem of jaw and hip fractures happening is not because these drugs are wrong, but because they are empirically used. They are used in patients with poor creatinine clearance. They are used in patients with hypocalcemia. They are very rarely monitored over a period of time. They are used in poor combination. They are used for a long period of time in patients where it should actually not be used. So there is no role of empirical treatment. It is not a casual treatment of anti-osteoporotic medication. You have to use it in the way like we discussed about chemotherapy medicines for AKT. In the same way, anti-osteo, these are hormones. They can really create challenges. In fact, with teriparatide now, the incidence of DVT has also been studied, which has shown to be up to 6%. And in elderly patients, 6% DVT. We have, how many patients have I given teriparatide in last 6 months? Maybe 100. So if 6 of them come to me with DVT, I'm in mess. I'm in deep mess. So if that is going to happen, it is not because the drug is wrong. It is because the dosages that we are using, the way we are using, it is the feasibility that we are checking or not, and whether we are monitoring them or not. And most importantly, as I mentioned, we generally tend to forget about general care of the patient. They are sarcopenic patients, and teriparatide bisphosphonates have no role in development of muscle mass. It is only by exercises and protein that it develops up. Sir, I'll come up to you and we'll discuss about it. We are
I think
running short on
Vishal,
time. We'll finish this.
it was an excellent comparison.
Thank you so much.
Superb.
Thank you.
And may I invite Dr. Amit? He's going to show us the surgical technique of vertebroplasty.
So after a very nice discussion by the previous speakers of the diagnosis and challenges of treating the osteoporosis and medical management, I think that's the very important part of the treatment of osteoporosis. And this is only one part of the osteoporosis that what we are talking about is an osteoporotic fracture. It actually deals with the whole body. So what I'm going to talk is in a very short presentation, when to do and what are the surgical tips for osteoporosis. Now, actually, I would say it's a losing game. Whatever we do in osteoporosis is a losing game, and we are fighting with a bull. So with this remark, I would go further that whatever I'm going to talk about a vertebroplasty or a surgical technique or whatever comes from now on, it's not 100% sure that it's going to work. And if it fails, there are a lot of issues that everyone can have. So you have to be very careful in choosing this technique also, right? Fine. So with this remark, I'll go further. And we know that usually the osteoporosis is a progressive. And this is a patient that I had. You can see, where's the pointer? Okay. So you can see that this patient came to me in July. And in November, there was complete progression. And this patient comes with a chronic disabling back pain. And then also they can have a neurological deficit. And the problem is whether to intervene this at this point of time or this point of time or this point of time. You just wait for conservative management and the patient falls into this category and you have already lost the bus of doing the vertebroplasty. So when to intervene and how to intervene, it's very, there are no landmarks, the evidences which are there that when to intervene in the cases of osteoporotic vertebral fractures. So that's a big question that I have put here. If you see the natural history of the pain, most of 60% will have a pain relief within 1 year. But out of this 60%, if you see, most of them will have a pain relief within 3 months. So natural history, if the patient does not have a pain relief within 3 months of time, then there are very less chance that this patient will have a pain relief further on. So that's the natural history of osteoporotic vertebral fracture. And that's a very important landmark article that you should wait for 3 months. And if it doesn't, then you have to intervene to get the pain relief. So is there an increased risk of mortality? Everyone knows that osteoporotic vertebral fracture increases the mortality. And the evidence says that about 10% in 7 years will live. 90% will die in 7 years of time if not treated in a proper manner. So it's very, very important that you treat them as early as possible rather than wait, because it's a downward spiral, as it says. It is said that once vertebral fracture, you get another vertebral fracture, you can get the kyphosis and then loss of pulmonary function, and then it's all downward spiral that we have. So management is conservative, as is already talked about. You can have bed rest, bracing, anti-osteoporotic treatment, and physiotherapy, as was told by the previous speaker, and Vishal very nicely narrated about the anti-osteoporotic treatment. That's the primary line of treatment once the fracture starts. But then comes the intervention of vertebroplasty and kyphoplasty. So that's what I'm going to talk about. Can intervention decrease the rate? So the thing is whether a vertebroplasty intervention can decrease the rate of mortality. And that's where if it decreases, then yes, definitely it's a helpful therapy. And this is a very good paper which came as a follow-up study of the 2 controversial articles of Lancet. This is again from Lancet only. That they did again a repeat multicenter trials, and it was found that vertebroplasty is definitely superior to placebo interventions or a conservative therapy for pain reduction in patients with acute osteoporotic vertebral fractures. So definitely vertebroplasty has a role. It's not a placebo. It has a role in these patients. So what are the benefits that we can get from vertebroplasty? Definitely, it decreases the pain. It decreases the use of analgesics. It increases the mobilization of the patient. And that's very important. More earlier you mobilize the patient of osteoporosis, less sarcopenia, less muscle deconditioning, and the patients will have better patient will be better rather than just keeping them in bed. You can have occurrence of chronic back pain. You can prevent the chronicity with the vertebroplasty. You can, this is very, very important, further collapse of the treated vertebral, height loss and kyphosis. Once you get a kyphosis and height loss, then there is no other treatment than to go for a surgery if you want to, because you cannot reconstruct by these vertebroplasties. Okay, so that's where you want to prevent it. So if you, before you go to this stage, it's better to stop the further collapse by doing a vertebroplasty, and that's the point of doing a vertebroplasty. So what does it do? It alleviates the pain, it stabilizes the fracture, it prevents further collapse of the treated vertebral body, and it gives a pain relief. There are so many mechanisms how it gives the pain relief, but it definitely stabilizes the fracture and prevents the further collapse. And that's why it's very important to do a vertebroplasty there. Now, which patients tend to respond the best? It's a single level or only a couple of levels rather than multiple levels. If you have a focal pain and tenderness corresponding to the level of edema on MRI. So if you see the MRI, if the patient has a fracture and then the patient has got a focal pain there, that patient may have a better result. If the fracture is present with less than 2 months, if it goes more than 3 months, then you are having a secondary problems of kyphosis, facet arthritis, and then the chances of getting the pain relief is very, very less. So there is a window period of waiting for about 1 to 1.5 months and up to 3 months. So that's the stage where you should actually intervene in the cases of osteoporotic vertebral fractures. And there should be no sclerosis or a fractured vertebra, or there should not be a vertebra plana by itself. So these are the things that you have to look for and as a patient selection for vertebroplasty. So this is a classical then, that's T1, that's T2. You have a fat suppressed image. There is a fluid sign. And this is the patient if presents you within 1 month or 1.5 months without pain relief. But actually, clinically, if you see the patient has got increasing pain rather than decreasing trend of the pain, then you can think of intervention at that particular phase. It's always better to do a CT scan whenever you want to intervene, because you have to check for the posterior cortex, because cement leakages are very common and you can have paraplegia for a vertebral collapse is not a very good thing. So it's always better to check where is the whether the posterior cortex is intact or not. Now, what are the indications of vertebroplasty? There are so many types of fracture, and this is a very good article from German Society, and they have recommendations of this in which type of fracture you have to go for a fixation and which type of fracture you can just go for a vertebroplasty. And they have divided that in osteoporotic type 1 and 2, where there is less than 1/5. These are the two cases where you can ideally go for vertebroplasty. This, when it is collapse greater than 1/5, then the indications fall slightly towards a fixation rather than just going for only vertebroplasty. And definitely in type 4, not in type 4 and type 5. They've also given the other scoring systems of whether the patient has got what is the BMD and whether there's deficit or not. But in general, 1 and 2 good for vertebroplasty, 3 doubtful, or maybe you may not, but 4 and 5 never to go for vertebroplasty alone. So that's very important message. And the other thing is you have to see the type of fracture. If there is intravertebral instability, definitely vertebroplasty is going to help. But if there is intervertebral instability, it's not at all going to help. So again, coming to that classification, just to give you an example, this is just a bone marrow edema. You can just intervene if you want to with a vertebroplasty in these cases, or just an end plate break. There you can just give a pain relief and start patient to early mobilization. So these are the good conservative versus vertebroplasty indications. If you go more than this, this is a doubtful case. Sometimes you may get away with it, and sometimes this will fail. But you can have any of these two. That's the type 3, which is a hybrid versus vertebroplasty, whether you want to add a fixation to it or not. But these two are definitely no-no. These two are definitely no-no. You can never do a vertebroplasty in a vertebra plana or when there is a disabling kyphosis, which is present. So these are very important things to look for when to go for vertebroplasty. Definitely, as I said, that if you have him sitting in supine X-rays, if the disc is already involved, there is no point doing vertebroplasty, because cement is going to leak inside and the instability is still going to persist. So intervertebral instability requires a fixation, not vertebroplasty stand alone. So that's another point that you have to look for when to go for a vertebroplasty. So when you decide that you want to go for vertebroplasty, these are the 5 commandments to perform for this procedure. You must be trained not for doing it, but when to stop cementing. I think that's very, very important, because you always have a itch that the cement is going, we just inject it. And that's where the problem starts. You should know how to deal with the leaks. If it goes, because it can leak into the it can cause a pulmonary embolism, it can cause go into the spinal canal and get a paraplegia. So you should know how to deal with these leaks also when you are doing this procedure. You must use good imaging equipment. You must use a good cement which has a good, which can be seen in fluoroscopy very well. Must use constant fluoro during the injection. So once you are inside the vertebral body, the fluoro has to be constant, because you want to prevent the leak. Or maybe in a pulse of about maybe 1 second, you inject, stop, inject, stop. That's what is required, and must be used for proper indication. So if you follow these things, then this is a good technique. Just a small video for this. A female 80 had a history of Parkinsonism, old fracture of D12 and L1, and there was a fracture at D11. These were old, and you can see that there is a cleft which is there. So there was a fracture of the upper end plate, and that's just upper end plate which was involved, not a full fledged. The patient is usually in a local anesthesia in a prone position, and I mark it just maybe 1.5 to 2 centimeter away from the pedicle. And these are very simple equipments which are required. So that's the pedicle, that's the midline. I go about 1.5 to 2 centimeter because I use a single needle technique, and I want that needle should go inside the. Can you stop the sound, please? Sorry. Can you stop the sound? All right. So once you go there, I do a injection right where my spot for the needle has to be. It has to inject the periosteum and then come out from there, and it has to produce a wheal. And it's very important that the patient should have a total pain relief till that time when the needle goes. And then I mark again with the knife the same spot where I want to enter, just to put a stab incision there, which goes up to the fascia. So the needle has good access. I use this needle, which is quite long, which is good. It's a disposable one, 11 gauge. Once you touch the vertebral body, you see exactly that you are on the lateral part of the vertebral wall, the pedicle wall, and then do a gentle tapping. It does not require a big force because it's osteoporotic. Just a gentle tapping till the time the needle goes up to middle of the pedicle. Once it goes up to the middle of the pedicle, and then you take the lateral shoot, it should be at the pedicle body junction. If it goes up to the pedicle body junction, then you, with the help of a gentle movement, you can just insert the needle a little bit more exactly at the fracture site where the upper end plate, there was a fracture. So you also check that it goes up to the midline. You always aspirate and try to take the biopsy or whatever the fluid that comes. And then that's the cement mixing. There are different types of cement which are available. You should be comfortable with whatever the cement which are there, and you should know the cement properties. So I would always try to use only one company cement because I am very much confident that it sets at that particular time. You have a paste-like consistency. So that's a paste-like consistency. And then you fill up the syringe. I usually take 2 cc syringe, not an insulin syringe, but I take usually a 2 cc syringe. And then I fill it up. And this is very important that it has to have a paste-like consistency, like when you put it. And because you don't want to put it in the liquid form, there will be more leakage and more problems of embolism. And then that's a fluoroscopy. And you don't have a control. Once the cement goes, you don't have a control where it goes. So you just have to check it under fluoroscopy that how it is going. But actually it is filling the fracture gap. And if you see that it is filling the fracture gap, that's fine. And then you have to use this plungers. Sometimes the cement is so thick that you might have to use the plunger. but that's good. That will prevent the leak, and we don't want to put the cement inside. And you can see that's thickening there, which is occurring at the same place. And then you check again in AP also that how it has filled up the vertebral body on the other side. Yeah, so that's the AP. And you can see the whole fracture gap has been filled with the cement. And then you take it out. While taking out, you do a screwing movement so that there is no pedicular tail which occurs, and you check that the cement is not coming out. That's a very small puncture wound which is there. And you always, because you are doing in local, you always check the movements that everything is fine. The cement volume to be injected is not more than 4 to 5 ml. More the cement injection, there are more problems actually rather than less. So you just require to stabilize the spine. So that's the thing. So there are certain issues with the vertebral augmentation, and there are two issues which there is a recompression of the same level, and that's where the problem lies at, and the incidence is around 10% to 37%. And why this recompression occurs and revision is more difficult to, in these, once you have put in the cement, the revision becomes very, very difficult. These are the red marks: intervertebral cleft, amount of cement injected, restoration of vertebral height. So if you restore, you have a good kyphosis, and if you restore it much more, then it is further going to collapse much more. If you have intradiscal cement leakage, and if the cement distribution is not proper. So these are the risk factors where you get the secondary vertebral fractures. And there are the other important thing is an adjacent level fracture, and that range is around 18 to 51. So there are problems around 20 to 30% of the patients, whether you get the same level fracture or a refracture in the same patient. Again, you can see this patient that was immediate. This is 1 month. We did the vertebroplasty, and in 2 years' time, it's totally collapsed. There is a upper fracture, and now the patient has again a problem. So these things can happen. So you have to use this vertebroplasty very, very carefully. And actually, in our practice, the rate of vertebroplasty has gone down drastically than when it started at that time. So analysis of these fractures, again, the same high volume injected. There is a kyphotic angle, which is more. There is cement leakage in the disc and pre-existing fractures. So these are the important risk factors which are there. So in summary, VCF increases the mortality, yes. 40% of the patients with VCF will have chronic low back pain if left untreated. VP and KP are effective in select group of patients not improved by adequate conservative trials. So adequate conservative trial is very, very important. And technically careful for doing VP and KP, because cement volume, cement distribution, and cement leakage increase the chances of secondary fractures. And definitely always important to start with aggressive anti-osteoporotic treatment with VCF. But definitely it produces smile in select group of patients. Thank you.
Thank you, Dr. Amit. We have a question at the last. Maybe we can move on to the last session.
I think Dr. Mihir, yeah.
So osteoporotic fractures are low injury and low impact fractures. And if medical management heals all and the rest can be managed by vertebroplasty, why and when do we need surgery? And if surgery is required, being a low traumatic, low impact fracture, can we not do short job, one level above, below, or treat them like simple burst fractures? Over to you, Dr. Mihir.
There were two important statements made by the last two speakers. One was Vishal saying that an osteoporotic patient is there for all throughout your life and her life. So they are going to follow you all through, and you need to follow them all through. And second is that excellent picture shown as a thin, fragile lady portraying as a bull charging towards you because you have no answer to it. So osteoporosis is a part of life. It is not a disease. All of us are going to lose calcium. All of us are going to become osteopenic, and all of us are going to become osteoporotic. So as the bone rarefies, it not only becomes fragile, but its capacity to heal also goes down. And that is why you need to be very, very careful of osteoporotic fractures, because it not only creates a fracture, but it also creates a setting for the next fracture. So what are the problems in healing? It is an anterior column failure in compression. The discs are separated from the end plates with a jerk as the fracture collapses. So it creates a relative intravertebral as well as intervertebral instability in almost all cases. The nature tries to heal that. And then it progresses to a middle column failure and creates a neurological issue. So this is how osteoporotic fractures. Now this is what Amit just pointed out, that an osteoporotic fracture cannot be treated on day one. आप ये tablet ले लो, आप सो जाओ और 3 महीने के बाद देखते हैं. No. An osteoporotic fracture has to be followed up on maybe 3 weekly, 6 weekly basis, and it has to be carried to conclusion. Otherwise, it will keep collapsing and will keep creating nightmares for you. We know that osteoporotic fractures create a vacuum inside the bone because of collapse, and these vacuums will open and close with every movement that the patient makes. And that is why these fractures will create pain while turning, while getting up, while changing positions. And these fractures in morbid patients, like Amit pointed out, are a serious threat to worsening their medical complications. Within a month, these 78-year-olds and 88-year-olds get admitted to ICUs because of hyponatremia. That's the first presentation of a complication of these fractures. So be wary of these big vacuum signs. They are set to collapse, and try to control them at the earliest. Again, this is what Amit pointed out. It is not an intravertebral instability. It is an intervertebral instability, and it is going to affect the segment above it. It is going to create a collapse, and it is going to create a setting for further and further fractures. So any kyphosis which is more than 20 degrees has to be taken seriously. It is better to get a CT scan and assess your posterior elements and middle column very, very carefully. So this is an example of what Amit showed, that there is a subsidence of the next bone, creating a setting for the next osteoporotic fracture. Luckily, in this case, it healed well. But if you observe these phenomenon, it is better to stop them at the earliest. Don't wait for a conservative treatment. First do a vertebroplasty and then start your teriparatides or do whatever you want to do. Otherwise, the third fracture is on the way. Now, you have intravertebral instabilities. Now, these fractures are extremely mobile, and that mobility will create a threat to your spinal column. It will create a threat to your spinal cord. And if the patient gets up from the bed and finds that he or she is buckling, it's an imminent sign of spinal cord compression, and these fractures require immediate stability. Do not wait for them to heal. You cannot put these patients on a bed. So what are the causes of neurology? It is a burst fracture. So it can retropulse and cause a cord compression like any other fracture. Or you can have a dynamic buckling of these fractures. Or you can have what we call as an accordion effect. That means these fractures creating tuck, 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 tuck kind of movement. And the spinal cord keeps getting stretched and develops an cord edema. So these are the kind of fractures that we are looking at. So if you have a burst fracture with retropulsion, the diagnosis is very clear. You need to do an anterior stability. Now, vertebroplasty is not reconstruction. Vertebroplasty is temporary reconstruction. Nowadays, you have percutaneous screws. So you have a simplistic method of controlling these fractures. But you have to understand that screws and vertebroplasty can loosen out. And therefore, segmental fixations are to be discouraged. And you have to use longer fixations so that you control these fractures a little better till the time they heal. Because vertebroplasty is not healing. So this is what you need to understand. The second phenomenon is that accordion effect, which in this case kept on compressing the cord. And the patient landed up with a neurological deficit after 3 months. So this is how late a neurological deficit can present after a vertebral collapse. Now, this is what Amit had shown, that if you do not watch these fractures, they collapse and they cause a secondary kyphosis presenting with a complication. which may require bigger and bigger surgeries if you allow these fractures to evolve. So in this case, we had to replace that body with a cage. And this is how that patient resolved. Now, this is a very interesting phenomenon. This fracture, we thought we had controlled with a vertebroplasty, but the patient still had an accordion effect. This patient was a doctor. He went back to working and still had an accordion effect around the vertebroplasty, developed a cord compression after 6 months. And we had to restabilize that spine using a posterior fixation. So these patients are like a charging bull. They keep coming back to you. So this is what Amit tried to show. Now, this is a segmental fixation around a vertebroplasty. But see how the cement is settling. See how the cement is toggling. So a segmental fixation cannot control these fractures at all. And you have to use at least 2 levels above and 2 levels below. Now, what are the problems with vertebroplasty? Plenty. You have adjacent segment collapse. You have same segment collapse. You have lots of problems coming up. Sorry, what is this? So misplaced right now. This is a variant of an osteoporotic fracture in an angstpon. Now these patients are different from an ankylosing, a simple osteoporotic fractures, and they develop a very, very tight stenosis. And therefore one needs to do a very aggressive surgery on them, control the fracture, decompress at the earliest. Now, this is a very rare thing, but this is how the fracture separates the disc from the end plates. Now, if you see this patient developed an osteoporotic fracture here, there, the fracture healed, and within 2 months, he had such a huge disc extrusion, which caused paraplegia. So this is a disc herniation adjacent to the osteoporotic fracture, which you see. You have to just observe it and you will recognize this in a lot of patients. A tricolumnar instability. Now you have multiple osteoporotic fractures. The patients start getting osteoporotic. Never use a segmental fixation in these patients. And these patients will keep coming back to you. They keep coming back to you for various reasons. Now, if you see this is a multiple osteoporotic fracture, stabilized, looks well, everything is hunky-dory. Patient comes back to you after 2 years with this. So she still comes back to you as a raging bull. Thank you.
We'll have an open discussion to any of the questions for osteoporosis. Any questions so far? Ranjit, Tarun, any delegates? So with this, I think we'll just have a conclusion to the session. We had 4 hours of IOA and ASSI combined spine symposium. And to end the session, I would like again to thank the Indian Orthopaedic Association for inviting Association of Spine Surgeons of India to conduct a spine symposium here. Tomorrow morning, again, a second version of IOA ASSI spine symposium is going to be happening tomorrow morning, and tomorrow is even more interesting, which is thoracolumbar trauma, spine trauma, and cervical myeloradiculopathy session happening tomorrow morning from 9 o'clock to 1 o'clock in the same hall here. We look forward to seeing you here again. And the program will be relayed both physical and virtual from 9 a.m. till 1 p.m. tomorrow noon. I take this opportunity to thank the Rajasthan Spine Society members, Dr. Girish Gupta, Dr. Chirayu, Dr. Lalit, Dr. Tarun, Dr. Mahendra, Mohit Biani, IP Agarwal, and all of the guys around. I also like to thank the, Mementos, yes. I also like to thank the faculty of Association of Spine Surgeons of India, Dr. Ram Chadda. He has to join some session in the other hall. Dr. Mihir Bapat, Dr. Amit Jhala, Dr. Ranjit Unnikrishnan, and all the members who have made this a possibility. And on behalf of IOA, ASSI, thank you all the delegates for attending this. We look forward to seeing you tomorrow. Osteoporosis is always a challenge, and I'm sure it is going to be a challenge to be discussed in coming more years. May I take this opportunity to felicitate our faculty members with a small token of appreciation from the IOCON IOA organizing committee. The senior most member here, Dr. Amit Jhala, sir. Dr. Tarun, to please felicitate. A round hand of applause for Dr. Amit Jhala for giving time from with busy practice and coming over. May I welcome Dr. Mihir Bapat, and may I take the honors to I call upon Dr. Ranjit Tunnikrishnan to please come over. I take again the opportunity to I now call upon Dr. Lalit Sharma, though he's a local host around, but I still take the opportunity to thank him for coming over. Girish, he's been instrumental in getting the whole team from local organizing. And Tarun, my right, left hand. I request you all to please join us again tomorrow morning. Yes, and for me,
Dr.
I take
Amit
the.
Zala, would you please visit Dr. Vishal Kundani? Proud privilege.
Thank you so much. Have a great night. We have a inaugural dinner tonight here, so we look forward to all of you to seeing you there. Thank you so much.
Thank you.
Thank you, buddy. ललित सर बहुत दिनों बाद कोरोना के पहले के बहुत बढ़िया अपन 88 में आपने